Hello. Connect ಆದ? Hello. கேக்குதா முபின்?
Yes, sir. Audible, sir.
Audible. Okay, right.
Shall we begin? I'll wait for.
Yeah. Kamachi says okay. How many have joined so far?
So far 9 have joined.
Only 9. Okay. Ask him if any more are coming or we will start. Ask Dr. Kamachi.
Yes, sir.
அவரே லாகின் பண்ண மாதிரி தெரியலையே.
Confirm. Sir, login try. 2 minutes. 2 minutes la login பண்ணிறேன் sir. Is on the process of login.
சரி. We'll wait also. You are presenting the first 2 questions, right?
Yes, sir.
Hello, good evening, sir.
Good evening.
Good evening, sir. There's a small issue with the network in my laptop, so I connected with my mobile.
Okay, okay, no
Am I
problem.
audible, sir?
Yeah. Clear,
Yes.
clear.
Yes. On behalf of Raisa and our beloved Professor Sami sir and all my teachers, I welcome you all for this Raisa academic session DNB for the benefit of DNB students. This time, with the kind permission of Professor, I have requested all our DNB PGs all over Indian Railways to actively participate by making use of this session and prepare answers for the theory questions which are either straightforward or sometimes you'll have non-precise answers due to some vague questions. So we'll take the help of our professor in defining and pre-sharpening our ability to present the answers in the perfect way during our exams. So without wasting much of our time, I request our professor to start the session, sir. Thank you, sir.
Thank you. Good evening, and very happy to meet you after a gap of 2 months due to the second wave. Hope the second wave ends and no more waves happen, and it becomes a smooth ride for all of us in future. And with your exams, theory exams, dates having been announced December 16th to 20th, I heard it's at DNB students theory exam. So hardly you have 3 months left for the preparations. So we'll try to um, uh, read as much as possible within this short spell. And a few tips I would like to give for the students who are going to appear for their theory exams. All of you have come across many theory exams in your undergraduate course and then your entrance exams and all that. But the DNB theory exam, actually you have 4 papers and each paper has got 10 questions, and each question sometimes may have 2 or 3 subdivisions also. Sometimes one full question is if it is an anatomy or a physiology question, that is the pattern they give. And for this 10 questions, you have 3 hours, which means you have hardly 18 minutes for each questions, because 3 hours is 180 minutes. Divided by 10, you have 18 minutes. So I have heard some students saying that they found a want of time for completing the paper, because some questions needed an elaborate answer, and by the time they complete it, they found that they could not have time for 1 or 2 questions at the end. So this sort of omitting the questions should not happen when you appear for your exams. So what I would suggest is, as soon as you get the question paper, and the other pity is in the last 2 exams, they have not been giving them any printed question papers. It has been projected in the monitor, and you have to note down from that and complete your papers. That is another new thing that is happening. So with all these handicaps, what I would suggest is you go through the questions quickly, select the questions you know well, and then plan your timing so that you complete the answers within the maximum 18 to 20 minutes for questions which are very elaborately asked, and try to make up by answer the small answer questions which are also given to adjust the timing, so that you don't omit any questions unless you don't know the answer completely, where you cannot write something wrong and then I was told that sometimes they introduce negative markings also. So in order to avoid all that, you better and repeated practicing when you are in these 3 months with your writing experience at home or in your institution in your free time is another way of improving your writing ability to complete the paper as quickly as possible. So with these few tips, I would like to invite Dr. Mubin of Railway Hospital, Perambur, who is going to answer the first 2 questions that have been given. Total of 8 questions only have been given this week. So he will be taking up the first 2 questions. Yes, Abhin, you can start.
Good evening, everyone. Good evening, sir. Today I will be presenting on bronchospasm, its differential diagnosis, and how do you manage a case of bronchospasm. Bronchospasm is defined as sudden constriction of smooth muscles of the bronchus and bronchioles, and it manifests as expiratory wheeze and prolonged expiration with or without the increased inflation pressure in invasive post-operative ventilation. It is more common in patients who are already having pre-existing airway disease, and absent sound with increased inflating pressure may also show as an example of severe bronchospasm wherein zero air entry is seen. There are various differential diagnosis for a case of bronchospasm. Patients having sudden anaphylaxis reaction or aspiration either during mask ventilation or in a laryngeal mask airway, or misplaced or thin endotracheal tube, inadequate depth of anesthesia, pulmonary edema, acute respiratory distress syndrome, or even atelectasis, or sometimes drug-induced such as fentanyl-induced rigidity or protamine reaction, and even pneumothorax can manifest with features suggesting of bronchospasm. And before proceeding, we will have to analyze a case presenting with bronchospasm INTRA. We will have to follow a small algorithm called cover ABCD split approach, in which those pertaining to a case of bronchospasm are C color. Here we have to look for cyanosis or observed desaturation, especially with the pulse oximetry. For V, there are V2, whereas we will ventilate the patient by hand to kill the pressure with bag ventilation. Second, there are two V's. One, E1 and E2. One is checking the ET tube, whether it's misplaced or kinked or it is pushed into the esophagus or into the endobronchial intubation. Second is ventilate with alternate method. You have to remove all the circuits and then connect the ambulance so that you remove all those circuits that might have caused the increased resistance and present as bronchospasm. So coming to various signs of bronchospasm, as already mentioned, there will be increase in circuit pressure, there will be desaturation, there can be beats, which will either be or sometimes there cannot be a beat, there will not be any air. There will be rising VTCO2 and there will be prolonged expiration. Sometimes capnography will give a typical appearance known as sharp fin appearance. There will be a sharp rise and then at the beat angle it will fall straight down. And there will be decrease in delivery of the set volume. So there will be decrease in thyroid volume. These are the variations. So suddenly, how do you manage the case of bronchospasm? First, we will give 100% oxygen, and then we will keep the whatever procedure we are doing or surgery we are doing, so that the stimulus does not produce more bronchospasm. Then we will try to ventilate by hand, and we will also try to deepen the plane of anesthesia. And if the patient next, we will decide depending upon the patient is intubated or not. If the patient is intubated, then we have to exclude the class of esophageal intubation, C-tube, or endotracheal endobronchial intubation. And if the patient is not intubated by bronchospasm symptoms are appearing during a LMA insertion or during a mask ventilation, we have to rule out laryngospasm as obstruction by either mask or clot, and aspiration causing severe reaction as bronchospasm. Even with the ET tube placed, if you are unable to ventilate, we have to rule out all the causes mentioned above, and we will also try to check whether the obstruction is distal to the ET tube. If it is distal to the ET tube, we will try either to pass a smaller ET tube or we will push the obstruction towards one bronchus so that the other lung gets ventilated in the meantime. And by the time we have to shift the patient to a high dependence unit or ICU, and we have to do immediately do a chest X-ray, and then there are two types of treatments can be available. The first line of treatment is always the bronchodilator, usually salbutamol. Here we give 0.5% salbutamol, 1 ml, which contains 5 milligram of salbutamol, and you nebulize it, or you give 2 puffs of salbutamol, 0.1 milligram per puff, or you have to take the 0.5% salbutamol in 0.1 ml, make it a 1 ml solution, and then push it through the ECQ so that it will get absorbed. Second line of treatment, various types are proposed. One such that is magnesium sulfate. Here, magnesium sulfate 50 milligram per kg can be given IV over 20 minutes, up to maximum of 2 grams, or hydrocortisone 200 milligrams can be given in every 6 hourly. Third, you can even give ketamine. Ketamine can be given as 10 to 20 mg bolus, or as an infusion of 1 to 3 milligrams per kg per hour. In extreme of condition, we can even use adrenaline at the dose of 10 to 100 microgram IV at a concentration of 1 is 10,000, or nebulize it as a 5 ml solution at a concentration of 1 is 1000.
Completed? Right. So this question sometimes can be worded as describe the causes of a tight bag. That also sometimes can be the wording instead of asking directly as a case of bronchospasm. Sometimes the questions are worded like that. So if it is worded like that, what are the things you have not mentioned in this? Why do you want to disconnect and then ventilate with the ambu bag?
To remove all those resistance that might have caused the obstruction in the circuit system, reducing the
Is there any mechanical causes which are likely to mimic a picture of bronchospasm? Like any machine fault, like kinking of the tube or obstruction in the stuck valves? All these things also sometimes can produce. So you can classify the causes of bronchospasm into mechanical and patient oriented or patient related. Okay. And another important thing I think you have missed is not mentioned anything about asthma or COPD. Did you mention that? Patients who are a known asthmatic or patient with a hyperreactive airway, they are the ones who are likely to become or develop bronchospasm intraoperatively. Okay, so it can happen during the time of induction, either by your inhalation agent inhalation. Like what are the inhalation agents which are likely to produce or trigger a bronchospasm? Normally, all the inhalation agents are having some amount of bronchodilation, especially halothane is a good bronchodilator. On the contrary, the newer volatile anesthetic agents like isoflurane and desflurane, both are irritant. So inhalation of that in the initial phases in a patient with a reactive airway or a known asthmatic or a known COPD patient can trigger a bronchospasm. Second step is as you try to intubate a patient under lighter plane of anesthesia with inadequate induction and do a scopy and try to intubate, that again is a trigger for bronchospasm. Then intraoperatively, again same lighter plane, pain perception or sudden dilatation of an orifice, all these things can trigger a bronchospasm. Similarly, during extubation, neostigmine is one of the biggest culprit in stimulating a bronchospasm. Okay? Are secretions which are going to crack down. So all the three stages of anesthesia, induction, maintenance, and extubation or recovery are all notorious for precipitating a bronchospasm. Okay, so all those things have to be mentioned. And another important step is if the bronchospasm is severe and patient is desaturating, the first and foremost thing you have to say is call for help. That is also be mentioned in the answer. Okay, it is a very important point. If you don't mention that, you won't get any hand. And then you try to relieve the bronchospasm and improve the oxygenation. When you give 100% oxygen to improve the oxygenation, you said you will deepen the plane of anesthesia. How is it done? That also you should be able to mention. So what will be the ideal method of deepening the plane of anesthesia when the patient is being ventilated with 100% oxygen? He is likely to come out and become conscious. So how to maintain the anesthetic plane as well as improve the oxygenation? So a combination of propofol and ketamine, small doses of ketamine. Ketamine by itself is a good bronchodilator. So in dire situations of bronchospasm, when you want to maintain the status of anesthesia as well as ventilate the patient, propofol has got a good effect on suppressing the airway reflexes. Ketamine in small doses is also a drug which can sometimes be used in status asthmaticus also. So instead of giving the normal 1 to 2 milligram, which is a induction or anesthetic dose of ketamine, you give 0.5 milligram per kg body weight of ketamine. That will, along with propofol, will maintain the anesthesia and also help in relieving the bronchospasm. Okay. And if you suspect any allergic reactions, anaphylaxis or allergy, you must include an antihistamine also. So chlorpheniramine maleate is another antihistamine that has to be included. And of course, in severe asthma, which is not responding to the conventional treatment, you have mentioned magnesium sulfate, which is also very useful in this agents. And the role of phosphodiesterase inhibitors like aminophylline, which is not the first line of drug, but that is also one of the drugs which has to be mentioned. Okay. So, and lastly, of course, epinephrine or adrenaline is the choice if the spasm is very severe, provided you have ruled out all cardiac conditions or patient should not be in any ischemic heart disease or such problems. So this question needs to be um, presented in a more refined pattern with classifications and steps in the treatment. Of course, I have prepared a PPT for all the questions. I will show it at the end so that we can compare how you have prepared and what is my line of thinking. So you can modify whatever points I have said in your answer to make it a better presentation. Okay. Overall, you have covered most of the points, but a little more refinement will fetch you better marks, I think. Okay. Right. What is the second question?
Second question is regional anesthesia and role of anticoagulants.
Anticoagulation. Okay.
Recently, numerous anticoagulants, coagulant agents have been introduced and are in practice now. And so the use of this agent and central neuroactive blockade are common. One of the rare complications is vertebral canal hematoma, which can occur with the use of regional central neuroactive block with an anticoagulant. So the careful timing of administration of the drug and stopping of this drug before restarting them after a central neuroactive blockade or a epidural catheter insertion is necessary. Anticoagulants can be of two types. Either they can be a parenteral or an oral. Parenteral, it can be either unfractionated heparin, low molecular weight heparin, or fondaparinate. Whereas oral anticoagulants can be warfarin or a new oral anticoagulant such as direct oral thrombin inhibitor and the direct factor 10A inhibitor such as dabigatran and everolimus respectively. Coming to first unfractionated heparin. These bind directly to antithrombin 3 and also to factor 10A and thereby inhibit coagulation. These anticoagulant effects start immediately and last for 4 to 6 hours. And the anticoagulation effect of heparin can be monitored with APT, measuring APTP. And one of the advantages of unfractionated heparin is they have an antidote by name Protamine, which can utilize heparin activity. Heparin can be either given as a therapeutic or a treatment dose. If given as therapeutic, it is usually given as IV injection, whereas prophylaxis is usually subcutaneous. Depends upon the dose. For prophylaxis, you have to stop the drug 4 to 6 hours prior to insertion or central neuroactive block and can be restarted more than after 1 hour of removal of the catheter. Whereas in the case of treatment dosage, we have to stop the drug and we have to measure the APTP and we have to make sure that it normalizes before starting the central neuroactive block or catheter insertion. And similarly, can be restarted after an hour of removal of catheter. Whereas in case of low molecular weight heparin, here it only acts upon factor 10A and does not have effect on thrombin. So one more advantage is it has a longer half-life and it has a prolonged action in case of renal infarction. Two drugs that are commonly used are enoxaparin and dalteparin. And here the the effect of these drugs can be measured by measuring anti-10A factors array, but these are not usually measured. So the monitoring of these drugs are quite difficult. Here also you can either give in therapeutic or in a prophylactic dose. If given in a therapeutic dose, it can be stopped for 1 day prior, that is 24 hours. Whereas if you have given as a prophylactic dose, you can stop 12 hours before the procedure, and both of them can be restarted 2 to 4 hours after removal of catheter or central neurotoxic blockage. Next is Conserve, where it is a synthetic pentasaccharide mimicking the structure of heparin, but it has certain properties where it will only inhibit factor 10A similar to low molecular weight heparin, does not act on thrombin or platelet. Here it attains the peak concentration at 2 hours and has a half-life of 17 to 21 hours, and it is also impaired in patients with renal impairment. So usually calcitors are to be avoided in a patient receiving Conserve, but if central neurotoxic blockage is to be performed, it will be performed 36 hours after stopping the drug and can be restarted after 6 hours in case of surgery or central neurotoxic blockage. But if you have to restart after removing a epidural catheter, you have to wait for 12 hours. As the incidence of vesicular aneurysm are commonly reported, was reported frequently with Conserve. Next is oral anticoagulants. Here, most common is warfarin, which has been used in multiple scenarios such as patients who are prone to develop thrombosis, such as patients with valve replacement and patients on valvular disease and other cardiac illnesses. Patients are started on oral warfarin. It inhibits the synthesis of vitamin K dependent factors such as 2, 7, 9, and 10. And one of the advantages of this drug is orally taken, whereas the other 3 drugs are taken IV. But here, before starting the therapy, you have to stop the drug. Before doing the procedure, you have to stop the drug for 4 to 5 days, and you have to check the INR ratio, and it should be less than 1.5 before starting doing the procedure. In case if the patient cannot be stopped completely on warfarin, bridging therapy with one of the above mentioned a parental anticoagulant should be started, and they should be stopped according to their protocol. Here, you have to stop the drug for 4 to 5 days, check INR, and it should be less than 1.5, and then you can proceed with the mentioned central neurotoxic blockade or catheter insertion. And to restart warfarin, we can restart as soon as we remove the catheter. Here, in case if you are unable to reduce the INR less than 1.5, you can either give vitamin K injection or Preshposen plasma or prothrombin complex concentration. The other newer oral anticoagulants are direct thrombin inhibitors and direct factor 10A inhibitors. Direct thrombin inhibitor is dabigatran. This can be given either as our per day dose or every 4th hourly, depending upon the scenario. And it one more advantage of this drug is it inhibits both the thrombin in the circulation as well as those that are in the already formed clots. Here also it will be impaired in CKD, so you have to wait a longer time. And the peak effect will be around 4 hours and half-life is 17 minutes. Here, the insertion of central epidural catheter is contraindicated in those patients with dabigatran. And once we want to restart the patient, we can restart the drug after removal of catheter 6 hours after removal. Similarly, levodopa here is only it inhibits factor 10A, and it is also active for 7 to 11 hours, and it is avoided in central neurotoxic blockade, or if it is necessary, we have carried for 12 to 18 hours and can be restarted after 6 hours. These are all the oral anticoagulants. These are the anticoagulants. But recently, a lot of antiplatelets are also in use clinically, and this also will interfere with the placing central neurotoxic blockade or epidural catheter. Most common are aspirin, NSAIDs, and clopidogrel procedures. These are cianopyridines. So, as a short note on these drugs, aspirin at the dose of 75 mg up to 150 mg, there is no need to stop these drugs. But if these drugs are used along with other anticoagulants or antiplatelet agents, stopping of these drugs is necessary. NSAIDs usually are not withheld or stopped prior to procedures, and there's no contraindication to these drugs. But thienoparidine, these irreversibly block the platelet process. So this will cause completely block this. So we have to wait for 5 to 7 days prior to procedure in order to make the body reproduce the platelet that has been functionally impaired. So nowadays, dual antiplatelet therapy are being used for stents, those who are on stent placement. Usually for bare metal stents, we will give for at least 6 weeks, whereas in drug editing stents, you have to give for 12 weeks. So if you want to, if the patients has to be taken up for an immediate emergency surgery, there is always a possibility of hematoma and the excessive bleeding in this patient, as stopping the drugs for even 4 to 5 days in the early period can lead to stent blockage. So in these cases, we have to consider siropiprant. This is an IV GP3A receptor antagonist to tide over the situation in cases where you want to do emergency surgery in a recently stented patient. Otherwise, in general, this thienoparidine should be stopped for 5 to 7 days prior to surgery, and as soon as the catheter has been removed, they can be discharged. The other groups are G2-3A receptor antagonists, usually apixaban, FTP and siropiprant, and this will block the receptor for more than 10 days, and hence we have to wait for at least 48 to 36 hours for the platelet function to become normalized, and then we can discharge as soon as we.
Very good. That's a fairly elaborate one. But what I would like to suggest is you can start with what are the conditions where anticoagulation is indicated. So after mentioning those kind of pathological conditions where anticoagulation is routinely administered, if such patients come for surgery and you plan to give a regional technique, then only this problem of when to administer or not to administer, that doubt arises. So first thing I would like to say that you can mention those conditions where normally patients are put on anticoagulants, and what are all the different types of anticoagulants that are given to these patients. For example, if a patient has a ischemic heart disease and he has undergone CABG or something, he will be on mostly antiplatelet agents like clopidogrel or ticagrelor and other newer antiplatelet agents along with aspirin. On the contrary, a patient who is more prone for venous thromboembolism or pulmonary embolism, he will be on parenteral anticoagulant. You have correctly classified these drugs into oral and parenteral. But before mentioning that classification, I feel it will be better if you mention the conditions in which you commonly administer these agents, and then go to say all these points where you are going to administer all these the time intervals and what are the safe. And one more point, apart from the central neuraxial blockade of epidural catheter insertion and removal, you can mention that what are all the conditions where patients are on either oral or parenteral anticoagulants, in which you can safely administer a single shot subarachnoid block. That also is a point which you have to mention. For example, a patient who is coming for a vascular procedure with already on clopidogrel or some other parenteral anticoagulant agent, it is safer to give a single shot subarachnoid for a hernia surgery with a 29 gauge or 27 gauge spinal needle rather than trying an epidural and trying to put in a catheter. Okay, that is a safety measure. And in the regional techniques does not stop with only the epidural or spinal. It also involves a major plexus block like brachial plexus, supraclavicular or interscalene approach, where there are a lot of major vessels very close to the nerve plexus. They also you have to exercise good caution so that you don't puncture those vessels and produce a big hematoma. Okay, so in addition to your mentioning the timing duration, if you want to perform a limb block, say like a brachial plexus block or a lumbar plexus block or a femoral block, it is better that it is all done under strict ultrasound guidance so that there is no inadvertent puncture of any major vessel that is going to cause a problem. Okay, so that point also can be added to that. Right, good. Right, who is the next?
Thank you, sir. Thank you.
Thank you.
Next is Dr. Sai Dikshit.
Who?
Dr. Sai Dikshit.
He's,
Dr. Sai Dikshit.
yeah,
Yes, sir.
yeah. You are from?
He is our first year railway
Which,
hospital.
oh, Chennai only.
Yes, sir. Perambur.
Right. Okay. What is your question? Good evening.
Two questions, sir. First question, anesthesia problem during MRI. Second question is for post-op hypoxia causes and management.
Okay. Go ahead.
Question, sir. Anesthesia problem during MRI.
MRI.
Actually, it is a NORA, non-operating room procedure. Non-operating room anesthesia procedure, sir. Even though having many advantages with MRI, like providing multi-plane images, half-planing images in any plane, there should be some considerations to anesthesia, sir. Problem of MRI, remoteness of location, sir. Lack of trained personnel to assist in the emergency, and minimum considerations given to anesthesia requirements in design areas like lack of pipeline gases and suction, lack of vast gases exertion, and remote airway, limited patient access and visibility, need to exclude ferromagnetic components, interference or malfunctioning of the monitoring equipment due to magnetic field, degradation of images by radio frequency currents leads or monitoring equipment. To prevent degradation of magnetic field homogeneity, not to move any anesthetic or monitoring equipment once examination has started. Our main aims of the anesthesia during for MRI is absolute immobility, hypnosis, and amnesia. Maintain patient safety and comfort throughout the MRI and rapid recovery. Equipment should be MRI safe and MRI compatible.
Compatible.
MRI safe and MRI compatible. Safety issues, sir. Implanted ferromagnetic objects like the intraocular foreign bodies, scissors, oxygen cylinder, laryngoscope, and stillet. These are all move in the magnetic field, sir. They move in magnetic field and potential to damage some dangerous projectiles. And the implanted pacemakers and EEG and cochlear implants and cerebrovascular clips. These may inactivate or dislodge and may cause injury to adjacent structures. Metal objects or electronic monitors. These may produce radio frequency waves. The interface with the images generated by MRI or scanners. Alternatively, specially adapted monitors and equipment for it. And should be positioned as far as away from the magnet as possible. And thermal injuries. Radio frequency observed by the tissues and other objects produce localized heating. The heating is less than equal to 1 degree centigrade. They does not produce such dangerous thermal injuries. Noise. Most of these scanners in the range of 65 to 95 decibels, sir. They cause temporary or permanent hearing loss. And it is difficult to monitor the sound via interstitial or precordial stethoscope, sir. So have to wear ear protection like earplugs. And we have to consider in pregnancy, sir. First trimester pregnant women should not enter the scanning, sir. Most indications of the anesthesia in MRI, sir. Trauma, and shock, children, mental illness, and claustrophobic patients. Patient with severe movement disorders and learning difficulties. Patient whose position limited by the pain. In these situations, anesthesia is indicated in MRI. Contraindications for MRI. Obese patient may not fit in the bore of the magnet. And the cardiac pacemakers and ICDs should be is most contraindicated in MRI because heating of leads will occur or reed switch malfunction and ICD malfunction will happen. And as said before that first trimester pregnant women should not enter, so they contraindicated in the MRI. And the suspected ferromagnetic objects like intraocular foreign bodies indicated, and the ferromagnetic vascular clips is also contraindicated for MRI. Nowadays, the titanium clips exception, sir, because they are non-magnetic, non-ferromagnetic substances. The hemodynamic unstable patients who are with infusion pumps are also contraindicated for MRI because these infusion pumps are cannot be taken inside, so they are also contraindicated for MRI. Pre-op assessment, all female patients should be done the pregnancy test and assess of any implanted devices like ortho implants, pacemakers, cardiac implants, cochlear implants, aneurysm clips, intraocular foreign bodies. These and all should be pre-assessed. Monitoring in MRI is good. General principle conform to same as ASA standards. MRI compatible monitors need to be used. If not compatible, place is machines outside the scan room. Pass along the long cable through specially shielded holes in the wall. If it is in the room, monitors are modified to make them as compatible and placed at least 6 to 8 feet away from the magnetic board. MRI compatible anesthesia machines with piped anesthetic gases to be available. All gas cylinders are to be MR compatible. Special monitors are that we can use inside with some modifications like pulse oximetry with fiber optic cables. We can use that. And the capnography we can use, but there is a delay in obtaining signals as sampling tool will be longer. And NIDP can be used with safe provided connections of cuff with the hose or flashes. And precordial and the esophageal stethoscope are used less. ECG, sir, cables to be shielded and use specific electrodes, sir. And ECG is like pericarditis due to magnetic field in MRI. And padding should be placed between patient side and the monitor cable to prevent burn. Avoid loops in the cable and check for any exposure segment. Anesthesia management, sir. Types of anesthesia, most common GA with endotracheal tube or LMS. Children with 3 to 7 years require sedation, and older children often complain and often complain without any sedation. So we have the sedation. Younger children deeply sedated after having feed. Site of induction, sir, done on the tipping trolley in anesthesia room, best induced outside in MRI room, sir, where effects of magnet on laryngoscope and the equipment are not a problem. Airway management, sir, remote airway and mostly LMA is sir. Pilot balloon should be saved away from the scan side as spring insects may cause heart attack. And intubation of poor gag or pregnant patients with a pilot balloon saved away from the scan side. Airway should be clear, sir, as partial airway may increase respiratory movement and act as a image artifact. And the flexometallic tube should not be used because as these cause degrade images. And laryngoscope nowadays plastic with lithium batteries and aluminum strips can be used. Maintenance with CO or ISO and by Shiva, sir, propofol and propofol with removed central infusion as an alternative. Circuits should be very long to go into the chamber IV line is long enough to as a long extension line, sir. Contrast like gadolinium DTCG is having a very low incidence of anaphylaxis. After that, we can evac the patient once shifted back to induction area, sir, where conventional monitoring can be done. Sedation of MRI, sir. Adult oral benzodiazepines can be used, sir. IV sedation like midas and low dose of propofol with ramipril infusion can be used. Monitors like pulse oximetry, ETCO2 is possible. Conscious sedation does not ensure compliance due to noise, sir. So mostly it is avoid conscious sedation. And supplement oxygen and adequate monitoring is mandatory.
Completed? Yeah, oh, good. That's a very exhaustive. If it is asked as a short notes, you can't write all these answers in that within the short time that is available for you. So that's but you have prepared exhaustively. Again, as a few modifications I can tell you is first you must mention what are all the indications for giving anesthesia in an MRI suit. Okay, like as you mentioned, small children or uncooperative adults. These are the two categories who will require some sedation or anesthesia to keep them immobile in the MRI suit. Okay. After mentioning that, the first point you said it is about NORA. It is a non-operative room anesthesia. So whenever you mention NORA, you have to remember those mnemonics, SOAP ME, which you have to check, like suction, oxygen, pharmacy, airway, equipments, etc., and monitors, etc. And then first check up all these things because you know help will be available, or you should have a person who will be of great help to you, who is experienced in helping the anesthetist. The OT technician who has some experience in this should accompany you always when you go for a procedure like this. And you have mentioned all the details about how to keep the patient immobile and all that. A pre-operative assessment is important. And if you plan to give anesthesia, NPO status is also important. So it is that point you have to mention because you plan to secure the airway, give intravenous induction agents, all these things. It should be done as an elective procedure and the proper NPO guideline should be given to the patient. And the next thing is you mentioned about the MRI safe and MRI compatible. That explanation is little more elaborately to be given. When you say an equipment is MRI safe, that means it can be taken into the field, magnetic field of that MRI room, and it will not get flown off or it will not be attracted by the magnet. That is called MRI safe. But that equipment's functionality is not guaranteed. It may not function properly. On the contrary, when you say an equipment is MRI compatible, it can be safely taken within the magnetic field of that MRI equipment, as well as its function is also will be normal. It will not be interfered. Okay, that is the difference between an MRI safe, which is commonly asked in your Viva exams. When they talk about MRI, the examiners may ask you, what is the difference between MRI safe and MRI compatible? MRI safe is an equipment which will not be attracted by the magnetic field and fly off like your ferromagnetic objects, implants, and other things. But the functioning of that equipment, for example, if it is a monitoring equipment, you cannot guarantee that it will function properly. Even for that matter, a pulse oximeter, which may be MRI compatible, may not read correctly if you take it inside the room. Whereas MRI, safe equipment may not work properly. Compatible work is safer to take inside as well as the function is guaranteed. That is the difference you have to mention. And in addition to that, when you use because you mentioned all the steps in induction, maintenance and all that, the circuit that is commonly used is the Bain circuit for anesthetizing the patient or keeping the patient under anesthesia. You use a special type of Bain circuit which is 5.4 meters in length. The normal Bain circuit is only 1.8 meters in length. So this is 3 times more. So you use a long thing. And you said the safety zone. The safety zone is called the 50 gauge line. 50 GAUSS, Gauss line. Okay, that is the strength of the magnetic field. So anything beyond that 50 Gauss line or lesser than that, like 5 Gauss or 10 Gauss, is safe. If you go within that 50 Gauss line where the magnetic field will be much more stronger, then only all these problems will happen. So any equipment kept beyond the 50 Gauss line is much more safer. And another point is, if you are planning to give DIVA, as you said, the infusion pumps also should be MRI compatible. So that is another point you have to mention. One of the equipment which can malfunction is the infusion pump. Okay, so that also has to be added to this answer. Otherwise, it's an excellent elaborate preparation. Very good. Congratulations. Go ahead with the second question.
Second question is post-op hypoxia causes and management.
I think Kamachisalam should have made this question as perioperative hypoxemia instead of simply saying postoperative hypoxemia. That would have carried the value for a
10 marks.
full question. Yeah. Okay. Go ahead.
Usually, mild hypoxemia is found in patients who is recovering from anesthesia when supplementary oxygen is not given. Mild to moderate hypoxia is tolerable initially in young adults. Those PaO2 is 50 to 60 millimeters mercury. If like this, mild and mild to moderate hypoxia is prolonged, increased in duration and severity, then initial sympathetic stimulation will occur. It is replaced by progressive acidosis and circulatory depression. Features during hypoxia, restlessness, agitation, tachycardia, atrial and ventricular dysrhythmia. Late signs are appendicitis, bradycardia, hypotension, and cardiac arrest.
Very good.
Early detection of hypoxemia in post-operative room is facilitated by pulse oximetry. Confirmed by ABC, so we can diagnose and give and we can guide therapies by doing ABC. Hypoxemia usually caused by hypoventilation with or without obstruction, an increase in right to left pulmonary stent. Sometimes with the shivering may also increase the hypoxia. Diffusion hypoxia is mostly uncommon when recovery patients are given with supplemental oxygen. Hypoxemia due to hypoventilation without obstruction, usually in patients receiving supplemental oxygen, unless modern hypercapnia or increase or concomitant in the intrapulmonary stenting is present. Most common cause of hypoxemia during GA is decreased FRC relative to closing capacity and increase in intrapulmonary stenting. More decrease in FRC occurs following upper abdomen thorax surgery. Loss of lung volume may occur due to microatelectasis and not identified as chest excess. Semi-upright position in this situation may help to maintain FRC. Intraoperative causes which increases right to left intrapulmonary stenting are to cause atelectasis by prolonged intraoperative hypoventilation without adenovirus and unintentional endobronchial intubation and lobar collapse from bronchial obstruction by technicians or less. Pulmonary aspiration, pulmonary edema, and large flow effusion, pneumothorax may cause intraoperatively cause atelectasis. Can diagnose pulmonary edema by presence of deep and pink swarthy fluid. There are symptoms in pulmonary edema, sir. This occurs due to left ventricular failure, ARDS, and relieving of prolonged airway obstruction, which is relieving of prolonged airway obstruction. This is called negative pressure pulmonary edema. Sometimes wheezing may also see primary obstructive lung disease, sir. also in intrapulmonary stenting. Pneumothorax, this usually occurs by following a central line placement of the supraclavicular intracostal block. Abdominal or chest trauma fractures, fixed causes decrease in FRC, and any neck dissection, thyroidectomy, tracheostomy, gastrectomy, any intra-abdominal procedures like laparoscopy procedure may cause pneumothorax. And during the postoperative ventilation also, those patients having subpleural left, that patients during postoperative ventilation may also develop pneumothorax. Treatment, sir. First aim of treatment is provide oxygen therapy without postoperative ventilation. Relief of any existing airway obstruction with airway management. Oral or nasal airways and oropharyngeal suctioning. For moderate hypoventilation and hypercapnia, 30 to 60% oxygen enough to provide hypoxia. Patients with pulmonary or cardiac disease require high concentration of oxygen guided by SpO2 or ABD. Patient with severe persistent hypoxia should be given 100% oxygen via NRBM or LMA or ET2 until cause establish an appropriate therapy is needed. Control assisted mechanical ventilation is necessary. Chest X-ray should be taken in upright sitting position, valuable in assessing the cause of the hypoxia. Assessing lung by doing chest X-ray, you can assess lung volume and heart size, and you can demonstrate pneumothorax or any reflectasis or any pulmonary. Pulmonary aspiration infiltrates initially absent. In pneumothorax, chest X-ray should be taken at the end of the end expiration, help to identify the pneumothorax. In ET tubes, we can have to take chest X-ray to identify the exact location of the ET tube, whether it is endotracheal or endobronchial. Best is a transthoracic ultrasound to assess the ET tube position already intubated patient. And rule out bronchospasm, in the patient we have to give aerosol bronchodilators, steroids, and potential in any potential or partial obstruction we have to give resting mixture of epinephrine and corticosteroid. We have to give both. Many fluid overload patients dietary should be given, sir. And positive end expiratory pressure ventilation or continuous positive airway pressure is indicated in patients in hypoxemia who in spite of 50% of oxygen, we have to give positive end expiratory pressure ventilation. In any re-expanding lobar reflectance by bronchial flux or particulate aspiration, we have to do therapeutic bronchoscopy. In any intubated patient with secretions or debris removed by suctioning and lavage, and malposition of ET tube should be position.
I finish? So this is why I said the question should have been worded as perioperative hypoxemia rather than postoperative hypoxemia, because postoperatively, majority of the times we extubate the patient and send them to the ward, and then only we encounter that they go in for desaturation and hypoxemia persists. This is what happens majority of the times. Very rarely you send the patient with an endotracheal tube to the post-operative ward unless you are not very happy with the recovery and patient is not obeying your commands and respiration is shallow. You are neither inclined to ventilate him nor you don't want to extubate him. That dilemma is there, you send them with the tube. Otherwise, normally we extubate, we feel that it's okay and send them, and then post-operatively they get a call saying that the patient is desaturating, hypoxic, and that is what is happening. Okay, So here it is better that you always classify them into pre-operative conditions of the patient, which can result in post-operative hypoxemia. That is a very important problem. So as I said earlier in the bronchospasm also, if the preoperatively patient has either a cardiac or a respiratory disorder, those are the patients who are likely to develop either intra or post-operative hypoxemia, which are likely to be getting aggravated. Okay, so that word about all those conditions like congestive failure, a patient with cardiomyopathy, ischemic heart disease, reduced ejection fraction. So all these patients are the more potential candidates. Similarly, patients with COPD, bronchial asthma, or reactive airway diseases, all these patients are also potential candidates who can develop post-operative hypoxemia or intraoperative hypoxemia. Okay, so the next important thing, what I didn't find in your method is repeatedly you have been mentioning only about pneumothorax, pulmonary edema, and all these things, but you have not mentioned anything about the intraoperative drug usage, the over sedation, and other things which can result in hypoventilation and hypoxemia. Okay. For example, intraoperatively, you have used too much of morphine or fentanyl, and patient is under depression because of the narcotics. That is another important reason for the post-operative hypoxemia because of shallow breathing and inadequate oxygenation. And very first opening, you can say about the different types of hypoxemia. One is the hypoxic hypoxemia. Second is the in the histotox. I mean, what are the four types? Hypoxic, stagnant, and histotoxic, and anemic. These are the four types. Hypoxic, anemic, histotoxic, and stagnant or cardiovascular problems. So if you mention those four types, you will know under which category the patient is likely to get into hypoxemia. So if the patient has a preoperative hemoglobin which is very low, then that patient you can expect him to have some amount of hypoxia postoperatively. Okay, so these four categories you can mention and then fix in the patients under those categories and then try to find out whether they require any correction before surgery and management, or whether you have to anticipate these problems in them in the intra or post-operative period. Okay, if you classify that like that, it will be much more easier. And the role of supplementary oxygen, always we give some amount of oxygen after completing the anesthesia reversal in order to avoid what is called the diffusion hypoxia also, which is a very important pathology which can happen in patients who are very frail, and normal healthy patients may not have the problem. But these patients who are already having some problem, because we generally develop the habit of giving 100% oxygen at the end of the surgery, we do not commonly see this. But the juniors who are getting trained, if you don't give this oxygen and just like that allow the patient to breathe room air from anesthesia of a long duration, then there is this diffusion hypoxia is another one of the common things which can result in patient going in for hypoxemia in the early post-operative period. Okay, so these are all the points that I would like to add. Otherwise, it's a little vague question which you have to think and then answer. Okay? It's not a straightforward question. You have to think from all the angles and then prepare. Okay, right, good. Who is the next presenter?
Shukla. Next presenter is Dr. Preeti Shukla from JRH Mumbai, sir.
Pratik Shukla.
Preeti Shukla.
Preeti Shukla. There is one Pratik Shukla, I see.
He is from Assam, sir. Pratik Shukla.
Okay.
Dr. Preeti Shukla is from JRH Mumbai. Will answer the question, what is placenta percreta? How do you assess this patient? Describe the anesthetic management.
of a case of placenta PERCRETA.
Okay. I don't see his face.
Yeah, your mic is on, sir. Please ready. Dr. Preeti, please.
Yes, sir. Starting with the definition.
Can you switch on your video for a minute, madam? Let me see your face. Yeah. Thank you. Go ahead.
Yes, sir. Placenta PERCRETA is defined as abdominal invasion of placenta through the entire wall of the uterus to the uterine serosa and involving adjacent structures like bladder and bowel. Coming to the second part, how do you assess this patient? So preoperative assessment includes history and examination. History includes the detailed clinical history with present chief complaints of the patient, obstetric history, and history of present and previous pregnancy. History of any previous cesarean section, history of placenta previa should be noted down. History of any previous uterine surgery or instrumentation to be noted down. History of any multiple pregnancy should be noted down because all these are risk factors which leads to the placenta PERCRETA.
Very good.
Then patient should be evaluated for presence of any comorbid condition, and if patient is on any medication, that drug history to be noted down. And if a patient had history of any blood transfusion or transfusion related reaction, that should also be noted down.
Very good.
Coming to the examination, patient should be examined thoroughly. General examination includes the appearance of the patient, build of the patient, that patient is thin or obese, nutritional status. Look for the signs and symptoms of the anemia like pallor, pale conjunctiva, mucous membrane, tachycardia, hypotension, and also look for the effort tolerance. As in anemia, there will be decreased effort tolerance. Then coming to the airway assessment, it includes the evaluation of the Malampati grading, mouth opening, neck circumference, thyromental distance as pregnancy worsens the airway due to edema of the pharynx, glottis, and arytenoid. Then coming to the investigation, the basic investigation that I would be asking is CBC to look for anemia and as a baseline value to calculate the maximum allowable blood loss because I am anticipating blood loss during surgery and to check platelet count. Then I'll ask for the coagulation profile, PPNR, APTT, as major blood loss is anticipated, which would interfere with the coagulation profile. Baseline renal function tests like BUN and serum creat I would ask for, and blood sugar level and blood grouping and cross matching I would be asking for. And in special investigation, I would be asking for ECG to look for rhythm, rate, or if there is presence of tachycardia or arrhythmia. So a placenta PERCRETA patient is most likely to be posted for elective cesarean section with planned purpura hysterectomy. Then I'm coming to the third part, that is management. Management will include the anesthetic consideration. Under anesthetic consideration, first comes the difficult intubation due to upper airway edema, and so there would be a difficult intubation in pregnancy. Then there will be difficult laryngoscopy due to increase in breast size and increase in chest diameter. Increased risk of aspiration because delayed gastric emptying present in pregnant patient. So we should be considering rapid sequence induction with recoil pressure and giving anti-aspiration prophylaxis just prior to the surgery. Then we would be expecting massive blood loss and challenges of resuscitation during the surgery. Possibility of wide range of hemodynamic instability during surgery, maintenance of vital organ perfusion, and prevention of disseminated intravascular coagulation. Coming to the preoperative optimization preparation. Preoperative optimization of hemoglobin to improve oxygen carrying capacity of blood by giving oral iron therapy or considering IV iron therapy if time permits. And optimization of the patient's comorbid condition if at all it is present. Then coming to the preparation, patient preparation will be including informed consent, consent for blood transfusion, anti-aspiration prophylaxis just prior to surgery, and fasting guidelines as 8 hours for solid and 2 hours for clear liquids. We would be arranging minimum of 4 to 6 whole blood or PRBCs, platelet, FFP just prior to surgery as there is increased risk of bleeding. We'll be taking 2 wide bore cannula, 16 test cannula, and we should also consider central line as massive blood loss is anticipated. Then
Very good.
OT preparation, We should be keeping difficult airway cart ready. We should be keeping emergency drug cart ready, keeping syringe pumps defibrillator ready, keeping endotracheal tube of different sizes. We should be keeping fluid warmer, rapid fluid infusion devices, and hand inflated pressure bags ready. We would be keeping uterotonic drug like oxytocin, methyl ergometrin, carbapenem, etc. Then coming to the monitoring, it includes the standard ASA monitoring like pulse oximeter, electrocardiogram, non-invasive blood pressure monitoring, and tidal carbon dioxide. Then we should also consider arterial line for beat-to-beat monitoring and the central venous pressure monitoring for fluid resuscitation. Now, urine output monitoring, as it is a best indicator during blood loss, temperature monitoring. Then coming to the anesthetic technique, general anesthesia is preferred in such patients due to significant risk of bleeding, which is complicated by profound hypotension and estimated risk of coagulopathy secondary to massive transfusion. And due to prolonged duration of surgery, general anesthesia is preferred in such patients. The induction will be adequate pre-oxygenation should be given to these patients as there is decreased FRC as they are more prone for desaturation. Induction so injection thiopentone 3 to 5 mg per kg or injection propofol 1 to 2 mg per kg should be considered. Injection succinylcholine 2 mg per kg with rapid sequence induction with pre-coil pressure. Anesthesia should be maintained by 50% of oxygen with 50% of nitrous oxide and sevoflurane after delivery of baby. Hemodynamics. Under hemodynamics, restore adequate blood volume to maintain mean arterial pressure of 60 mmHg. If blood loss present, then initial fluid therapy should be started in a form of crystalloids and colloid, but it should not overused because it can lead to dilutional coagulopathy. If bleeding is massive or uncontrolled, massive transfusion protocol should be activated, and blood loss should be replaced with whole blood FFF and platelet in a 1:1:1 ratio. Use of inotropes if hypertension persists. Use of uterotonic therapy if PPH is there. Use of recombinant vector like Novo 7A, tranexamic acid, and rotten-based blood transfusion protocol as it avoids unnecessary blood transfusion in such patients. Then coming to the extubation, a patient should be extubated when patient is fully awake and alert, or delay extubation if there is hemodynamic instability or acid-based disorder is present. Then post-op management, analgesia would be maintained by a multimodal approach consisting of injection paracetamol in 15 to 20 mg per kg IV, injection fentanyl 1 mics per kg IV. Then monitoring will be including of ECG, saturation, NIBP, urine output, and temperature. We should be providing adequate oxygen to the patient and maintaining euvolemia. Complication of placenta percreta consists of disseminated intravascular coagulation, transfusion-related acute lung injury, acute respiratory distress syndrome, multi-organ dysfunction syndrome, acute tubular necrosis, acute renal failure, venous thromboembolism, genital urinary fistula, and genital intestinal fistula. Thank you, sir.
Completed?
Yes, sir.
Excellent. You are a primary candidate or a secondary candidate?
Primary candidate, sir.
Very good. For a primary candidate, it's a beautiful presentation. But where did you prepare it from? Which textbook?
Sir, I have taken this from many articles.
Many articles. Okay. Okay. Did you mention about the blood group of the patient in your pre-operative investigations?
Sir, I have asked for blood grouping and cross-matching during investigation.
Yes. Yeah. So did you not find one word that management of a placenta previa patient is a multi-dimensional or a multidisciplinary approach? Okay, that is the first and foremost important point. You have to keep it in mind. Okay, especially if you know by pre-operative investigation that it is a placenta percreta. What is the danger in placenta percreta?
As it involves the adjacent organs.
Adjacent organ, which is the most commonly involving organ close to the uterus? Urinary bladder. So should it something to be done about that before you plan for your cesarean section?
Sir, we can do MRI to see the extension.
No, normally what they do is they first do a cystoscopy by a urologist and then try to identify whether this PERCRETA is involving the bladder musculature also and protruding into the bladder. And also they put a stent or guide wire in the ureters so that it is easy to identify them without damaging them during the hysterectomy. And there are two options for the patient. You have to get an informed consent for the from the patient for a on-table hysterectomy along with the cesarean to deliver the child. Okay? So the procedure usually done is you do a classical hysterectomy, lower segment hysterectomy, hysterectomy, and deliver the baby and then close the wound and then proceed with hysterectomy. You don't allow the placenta to get separated and it will not come out also like a normal placenta. Okay. So the placenta has to be left in situ and then you plan for your hysterectomy by going on to ligate the uterine vessels and the fallopian tubes. Usually the ovaries are left behind in a younger woman and then the classical hysterectomy is performed. Okay, so that is the way these cases are managed. So a preoperative instrumentation by a urologist to identify any involvement of the bladder and the catheterization of the ureters is very important step in this. Okay, and it should be done by an experienced obstetrician and an experienced anesthesiologist should be able to handle these cases, right? And all the other points what you have said about difficult airway, the anticipation of difficult airway and all that. And you should never forget to make about the right wedge on the right hip whenever you make the patient lie down, especially with the for general anesthesia. Along with all other precautions you said, you should also mention about the wedge under the right hip or the right buttock to lift the uterus before you do the induction. That point should never be forgotten. And pre-oxygenation before GA is also a very important point that should also be highlighted more than mentioning it. 3 to 5 minutes of, because this elective procedure, the 3 to 5 minutes of pre-oxygenation is a very important step to prevent desaturation. And another newer thing which has come into this is, supposing it is a very mild form of placenta accreta or increta, and the woman is very insistent that they should have the uterus and they don't agree for a hysterectomy, then what are the options? Nowadays, they do what is called embolization, temporary occlusion of the vessels feeding the bladder and the placenta and the uterus, like uterine artery and the pelvic arteries and other things, and then proceed with the delivery of the fetus and remove that small portion which is attached, because it is just like applying a tourniquet to a limb and doing surgery. You can occlude those feeding vessels and then remove the placenta, administer uterotonic drugs, and then try to allow the uterus to contract and then take out the balloons and then allow the perfusion to go on. Okay. But there is always a risk of massive hemorrhage happening that should be explained to the patient, and getting the informed consent is a very, very important step in that. So the 2 points that you have to mention at the very beginning is, it is a multidisciplinary approach in management of this patient. Second thing is, these patients are usually done as a elective cesarean with a possible on-table hysterectomy. Okay, for both of this, the patient should have been given a consent with the information given in all the details. And the third challenge is, it is a possibility of postpartum hemorrhage, massive postpartum hemorrhage, which may require massive transfusion. So it should be carried out only in an institution with a well-equipped blood bank, which can supply the blood and blood products which are required. And intraoperatively and postoperatively, if there is a bleeding, you should have the point of care testing in the form of TEG or ROTAM, which is very important to identify what type of complication that has happened and what type of replacement should be done, whether it is RBC or platelets or FFP or cryo or fibrinogen, that can be identified only by using a TEG and totem point of care testing. Okay, so these are the few extra points that you have to add. Otherwise, you have made a very good presentation. Excellent. Okay, add these points to your answer. Congratulations. Thank you. Who is the next person?
Pratik Shukla, sir, from Maligaon NF Railway Central Hospital. He will be presenting the answer for what are the methods available to conserve blood, how will you assess blood loss, what is massive blood transfusion and its protocol, enumerate complications of massive transfusion. Over to Dr. Pratik Shukla.
Shukla, are you the one who presented anemia complicating pregnancy? Your mic is not on.
Unmute yourself.
Eh?
Please unmute yourself.
Yes, sir. Yes, sir. Sir, I was the one, sir, who presented
Oh,
that.
very good, very good. I remember your face because of your good presentation last time. Hope
Thank
you
you,
do
sir.
the same thing now also. Welcome.
Sir, I would
Carry
try,
on.
sir. Good evening, sir.
Yeah, good evening.
Sir, methods available to conserve blood loss is my first question. So, being an anesthetist, minimizing the blood loss during surgery is one of the prime most goal. So, one way to achieve this is practicing blood conservation, which can be done under two heads, using pre-op methods like optimizing the pre-op hemoglobin during pre-anesthetic evaluation via proper history, clinical examination and investigation, identifying the cause of anemia and treating it with iron and folic acid or parenteral iron or EPO, erythropoietin if required. Second step can be, sir, autologous blood transfusion, collection and subsequent infusion of patient's own blood, which includes pre-op autologous blood donation also. Third thing which we can do is acute normovolumic hemodilution, which is collection of predetermined volume of blood drawn out of patient just prior to the surgery, and the intravascular volume is maintained with asanguineous fluid like crystalloids or colloids. Fourth is hypervolumic hemodilation. So that in this we in vivo dilution of erythrocyte by creating hypervolemia using asanguineous fluids, and therefore reducing the erythrocyte blood loss. And this should be practiced only in case of absence of cardiac or renal diseases. Second subheading will be intra-op methods for blood conservation, like intra-op cell salvage, which is the collection and processing of the patient's own blood and retransfusion, and it can also be done in the post-operative phase also, sir. Second is practicing controlled hypotension, which can be defined as reduction of the systolic blood pressure up to 80 to 90 mm of Hg, or mean arterial pressure by 30 mm of Hg from the baseline, or mean arterial pressure to 50 to 70 mm of Hg. And it can be done using many drugs like clonidine, nitroprusside, nitroglycerin, esmolol, dexmedetomidine, and inhaled anesthetic will also help to this cause of us. So postural changes can also be done to conserve blood, like head up position, or the surgical side should be above the level of incision side should be above the level of heart, so as venous congestion is not there. So preventing hypothermia is also one of the major goal for conserving blood, because it will reduce post-op shivering, that will reduce acidosis, and that will reduce the chances of coagulopathy. Sir, augmentation of surgery with clotting factors like tranexamic acid with IV bolus doses of 12 to 15 microgram per kg, or IV infusion doses of 6 mg per kg per hour, or desmopressin, which is a synthetic analog of vasopressin, which increases factor 8 and 1 milligram factor, or using aprotinin, which is non-specific protease inhibitor. Sir, local infiltration of the incision site with vasoconstrictor like adrenaline is a very good choice. Use of tourniquet for peripheral limb surgeries, but using tourniquet should be a cautious thing, which should means we should rule out sickle cell anemia or peripheral vascular disease prior to use of tourniquet. Use of electrocautery, laser, USG scalpel by the surgeon will decrease blood loss. Promoting laparoscopic surgery will also decrease blood loss. Long complex surgeries are to be staged in multiple staging, and first stage, after completing first stage, a time period should be given so that hemodynamically patient can recover, and then second staging should be done. So use of fibrin glues, hemocoagulase, calcium acetate at the surgical wound can also reduce the bleeding, sir. So my second topic is assessment of blood loss during surgery. Visual inspection gives an inaccurate estimation. Thus, we can use given following methods, including clinical methods. According to American College of Surgeons, class of acute hemorrhage is divided under 4 classes: class 1, 2, 3, 4. Class 1 is around 750 ml of blood, that is 15% of the total blood volume is lost, and patient is tachycardic, around 100, pulse rate is around 100, but maintaining his blood pressure. Wide pulse pressure can be felt during this period of time, with respiratory rate up to 20 per minute, and urine output 30 ml per hour. So mental state of the patient during class 1 will be slightly anxious, while class 2 is 750 to 1500, that is up to 30% of blood volume, total blood volume. Blood pressure will be normal or slightly decreased, but pulse pressure will be decreased in these cases, and patient will be mildly anxious with urine output around 20 to 30 ml per hour. So class 3 is 1500 to 2000 ml of the blood loss with 30 to 40%, that accounts for 30 to 40% of total blood volume. Therefore, leading we can see that patient will be anxious and confused, and pulse rate will be tachycardic 120 per beats per minute, and pulse pressure will be reduced, the blood pressure will reduce, and so patient will be tachypneic around 40 to 30 to 35 per minute can be seen, sir. Well, class 4 is more than 2000 ml, that is more than 40% of the total blood volume. Pulse rate will be around 140, and blood pressure, systolic blood pressure will decrease by less than 80 systolic, and respiratory rate will increase up to 45 per minute, sir, with urine output, negligible amount of urine output will be there. Second method is using of hemoclu during intraoperatively, sir. Means prior to the surgery, blood on the table of surgery, if a long-standing surgery is there, just before induction, we can check the hemoglobin, and according to the blood loss, we can segmentally check the hemoglobin. Third is counting the soaked gauzes, assessing the floor spills. 4 into 4 centimeter of soaked gauze will have 10 ml of blood. Similarly, 13 to 30 will have 150 ml of blood. 45 into 45 centimeter will have 350 ml of blood. So counting this, and we can estimate the blood loss by this. And we should also take in account the suction containers, suction tubings, and so pooled blood beneath the patient's beneath the patient's. It should also be taken into account. So dry means, or else we can have a dry means prior to using of the gauze, we can have a dry weight of the gauze, and after so gauze can be weighed and nearly estimating by that, sir. 1 ml means 1 gram is क्या था? अच्छा छोड़ो रहने. Third thing is massive blood transfusion and massive blood transfusion protocols. Definition of massive blood transfusion is replacement of one entire blood volume within 24 hours, transfusion of more than 10 units of PRBC in 24 hours, transfusion of more than 4 units of PAT cell in 1 hour, replacement of 50% of total blood volume within 3 hours. So massive transfusion protocol describes the process of management of blood transfusion required in bleeding episodes by interacting with the via interaction of the treating doctor and blood bank, thus ensuring judicious use of blood and blood component. Massive transfusion protocol is activated by doctor in response to massive bleed, and only after transfusion of 4 to 6 units of RBCs, packed cells, packed RBCs. It is massive transfusion protocol is a predefined ratio of FFC, cryoprecipitate, platelets, and PAT cell in 1:1:1 or 1:1:2 as per the setting required, means as per the laboratory report suggest of the patient. Once this protocol is activated, blood bank ensures the rapid and timely delivery of all the blood components together to facilitate the resuscitation, and thus reducing the dependency on lab testing during resuscitation and decreasing the need of communication between the blood bank and the treating doctor. The limitation of massive transfusion protocol is that it's not yet standardized, so it is locally they have to so check it. And sir, if it is activated and patient does not require massive transfusion, then there is a huge loss of blood because of massive transfusion protocol. Complications of massive transfusion, it can be studied under two heads: immediate complication and delayed complication. Under immediate complications, problems problems related to secondary to volume resuscitation. It can be inadequate resuscitation or overzealous resuscitation. Inadequate resuscitation will lead to hypoperfusion, lactic acidosis, thus patient landing up into DIC. And overzealous resuscitation may lead patient landing up into transfusion-associated cardiac circulatory overload and interstitial edema, and dilutional coagulopathy or dilutional thrombocytopenia. The second heading is problem due to transfusion of large volume of stored blood, therefore leading to citrate toxicity and thus leading to hypocalcemia, hypomagnesemia, and acidosis. Hyperkalemia is also seen and it is associated with the storage of the blood. Means longer the stored blood is used, more the chances of hyperkalemia is there. Third thing is patient can land up into hypothermia because we are transfusing large amount of blood which is stored at lower temperature. Fourth thing is patient can land up into acidosis. Late complications includes a respiratory failure like TRALI. This happens within 6 hours of the transfusion. This is transfusion related acute lung injury. Second thing is transfusion related acute kidney injury. Third thing is sepsis. Fourth is thrombotic complications. Fifth is transmission of infection like HIV, HBsAg, and HCV. Since we are transfusing a lot of blood, either if one part is also defective, then patient will land up into having infection like this. Iron overload can also be a complication if not required blood, if patient does not require large amount of blood and we have transfusion. And sir, adverse reaction can occur at any time, sir, including adverse ocular reactions. Thank you, sir.
Very good. So you have not disappointed me. So again, a good presentation. In the first part of the question, conservation of blood, you have mentioned everything, but I can add one more thing: perfluorocarbon usage to limit the usage of actual blood. This is the artificial blood which can be added to that. So that also will help to reduce self-salvager and recycling of blood. That is another point that you can think of in major surgeries instead of using fresh blood. Okay, these are the 2 points that you can add to your already elaborate answer that you have given for that first point. And the second part, massive transfusion, you have to mention also about the hemolytic reactions, acute and immunological reaction, transmission of diseases, which are all common to any blood transfusion, that also have to be included in the complications of massive transfusion. And correction of citrate toxicity by calcium injection whenever you exceed more than 4 units of transfusion in a rapid fashion is a very important thing to prevent the cardiac suppression also. Okay, so those are the few points that I would like to add. Otherwise, it's a fairly nice answer. Thank you.
Thank you, sir.
Welcome. Okay, who is the next?
Next speaker is Dr. Pavitra. She's a primary DNB student from NRCH New Delhi, sir, Northern Delhi Central Hospital. She is our ADMO from Arakonam. She is right now pursuing higher studies in Northern Delhi Central Hospital. Dr. Pavitra.
Okay.
Over to you.
What is she going to talk?
She'll be talking on pathophysiology and management of postoperative shivering.
Shivering. Okay, right. A good topic.
Good evening,
Good evening. Can you switch on your video for a minute and then go back? Is your video working? Because I would like to see the candidate's face so that I get familiarized with them. Otherwise, it is like a dubbing studio. Okay? Hearing only the voice, not able to see the face. Your video is not working.
No, sir.
Right, okay, no problem. Carry on.
Sir, can you hear me, sir?
Yeah, I'm hearing you. I can't see you, but I can hear you.
Okay, sorry, sir.
Yeah.
Sir, the question for me is pathophysiology and management of shivering following anesthesia, sir. If I get a question like this, I will discuss the question in the following headings, sir. Introduction, incidence, risk factors, etiology, pathophysiology, pathogenesis, scoring system, clinical impact, prevention, and management, sir.
Very good. Excellent.
Sir, in the introduction, shivering is a physiological response to cold exposure, and the body's next step response in heat preservation next to vasoconstriction, sir. It is a syndrome involving involuntary oscillated contractions of the skeletal muscles. It causes heat production up to 600%, and it increases oxygen consumption up to 200%. Such it maintains the basic metabolic rate of the body is increased. There is facilitation of the jaw, face, and head, or the hyperactivity of the muscle of the entire body, lasting longer than 15 seconds. The incidence is 5 to 65% after general anesthesia, 30 to 33% after regional anesthesia, and the overall incidence is 34%. Sir. So the risk factors include the young age, and the most important risk factors is a low core temperature prior to the surgery, and the male sex and the female sex during labor, general anesthesia, sir, and the pre-existing sepsis causing vasodilatation. The etiology is intraoperative evaporation during skin preparation, radiation convection from the skin, cold IV fluids and irrigation fluids, humidification of the gases, and the general anesthesia causing altered thermoregulation, and the regional anesthesia causing peripheral vasodilatation, and the pre-existing sepsis causing vasodilatation. Sir. The pathophysiology of shivering, sir. The pathophysiology of shivering starts with the temperature regulatory system. The temperature regulator center is the anterior and preoptic area of the hypothalamus. The thermoafferents are the lateral spinothalamic tract going into the reticular formation, from there to the preoptic and anterior hypothalamus, and the thermoefferent is the alpha motor neurons. The neuromodulators are in hypothalamus: norepinephrine, serotonin, acetylcholine, dopamine, histamine. In the corpus cranial, it is melatonin, and pons, norepinephrine, serotonin, acetylcholine. Mesencephalon, in the mesencephalon, it is acetylcholine and enkephalin. Spinal cord, in the spinal cord, it is norepinephrine, serotonin, acetylcholine, and dynorphin. Based on this, we plan our management. So, since these are the neuromodulators, we modify these neuromodulators. And the thermoregulation in general anesthesia, there is altered thermoregulation mainly by the volatile anesthetics like isoflurane and the short-acting opioids which we use during general anesthesia. The volatile anesthetics cause the altered it is by the NMDA activation. The three mechanisms are: the first mechanism is by NMDA activation, causing the opioid as such inhibit the thermoregulatory response causing shivering, and the withdrawal causing hyperalgesia, and the shivering is as such is a sign of opioid withdrawal by acute intolerance. The short-acting opioids, example remifentanil, alfentanil, sulfentanil. And in regional anesthesia, it affects the central and peripheral thermoregulation. It increases the inter-threshold range. The normal inter-threshold range is 2 to 4 degrees Celsius. it increases the sweat threshold, and it decreases the vasoconstriction and shivering threshold. And there is redistribution of intravascular volume from the core to the peripheral compartment due to vasoconstriction, and there is sympathectomy below the level, and there is increased heat loss is there, sir. And the thermoregulation is has 3 phases, sir. The first phase is redistribution phase. That is during the first hour, there is rapid drop in the temperature from 0.5 to 1.5 degrees Celsius due to vasodilatation by the volatile anesthetics. And in the phase 2, it is a linear phase. This is due to heat loss by radiation, conduction, evaporation during the surgery. And the third phase is a plateau phase. The temperature is maintained. This occurs after 3 to 4 hours after general anesthesia. Here, the heat loss and the heat production are balanced. So there is a plateau phase. In the regional anesthesia, this plateau phase is absent. Sir, can you hear me?
Continue.
Hello, sir. So the scoring system is by Matthew et al. It consists of 4 scores, sir. The 0, there is no shivering, and in score 1 consists of mild facilitation of face, neck, and the ECG disturbances in the absence of the voluntary activity of the arm. And the score 2 is visible tremors in a muscle group, example the upper extremity or the lower extremity. And the score 3 is gross muscular activity involving the entire body, sir.
Very good.
The prevention is by maintaining the OD temperature, operating room temperature 21 to 23 degrees Celsius, and maintaining the intraoperative normothermia of the patient, adequate pre-warming of the patient 30 minutes before the regional anesthesia, and the use of IV vitamin 0.5 milligram per kg IV before general anesthesia or regional anesthesia, and the use of ondansetron 8 milligram IV during the induction prevents the post-anesthesia shivering, sir. And we have to correct the underlying problems like sepsis and hypothermia prior, and warming of the IV fluids and the irrigating solutions. The management is non-pharmacological measures and pharmacological measures. The non-pharmacological measures consist of warming the patient. There is active warming and the passive warming. The passive warming consists of maintaining the operating room temperature 21 to 23 degrees Celsius, and the using of insulators, cotton blankets, surgical drapes, plastic sheets. And active warming consists of forced warmers, forced air blowers, air warmers, and radiant infrared lamps. And opioid 0.35 to 0.4 milligram per kg. It's an kappa opioid, sir. And tramadol 0.1 to 0.2 milligram per kg IV, and butorphanol 1 to 2 milligram per kg.
Hello.
5 microgram per kg per hour infusions, and anticholinergic centrally acting physostigmine 0.04 milligram per kg IV, and chlorpromazine 10 to 25 milligram IV. In addition, we can give NMDA antagonist ketamine 0.5 milligram. Operative shivering. If associated with sepsis, we can give prostaglandin synthesis inhibitors, acetaminophen or aspirin, and glucocorticoids.
You completed? I think your audio has been troubling you. Right. It was a good presentation. Only thing what I can add to this is shivering after anesthesia can be first classified into normothermic and hypothermic shivering. That is the first and foremost important point that has to be mentioned there. It is not necessary that always the patient should become hypothermic to develop a shivering. If they develop hypothermia and then go for shivering, it is, as you rightly said, it's a protective mechanism to bring up the core temperature. And the main thing is the difference between the core and surface temperature are the one which is the decides the shivering threshold in the hypothalamus. Okay. And the definition of hypothermia is 33 to 35 degrees centigrade. If the core temperature drops between 33 to 35 degree temperature, then that is called the hypothermia. And the shivering threshold happens at 35.5 degrees centigrade. And another important point you have to mention is whenever you give GA, the patient who is normally a homeothermic individual, which means irrespective of the ambient temperature, they maintain their body temperature at the same level of 37 degrees centigrade. But under anesthesia, because of the interference with the conscious level, they become what is called poikilothermic. They tend to take up the temperature of the ambient or surrounding area. That is the reason why if the temperature, OT temperature is very low, patient tend to become very hypothermic very fast. That is the reason why we want to reset the OT temperature to normal level and also try to cover the patient so that they don't lose their heat further and become more and more hypothermic. When will be the patient having shivering with the temperature which is normal? One important point you have forgotten is the pain. So pain and temperature are carried by the same fibers. Okay. So there is an interaction when the patient is having severe pain. They also start shivering because of the transmission of both the pain and temperature transmission going through the same line, and that stimulates and triggers the shivering. And so patient with a normal temperature also can develop shivering. So and apart from the human consideration of relieving the pain intraoperatively, another important reason is if a patient has got adequate analgesia, the normothermic shivering will be very much reduced. Okay, that is another point. Otherwise, your preparation is a very good, nice presentation. And I think I have also prepared my PPT based on the same article which you have gone through by the thing. Okay. So,
clonic shivering and tonic shivering, sir.
Yeah, clonic and tonic shivering. Yes. Yeah. Right. Good.
The tonic shivering, which typically occurs in the hypothermia, and the clonic shivering mimics the pathological clonus. It occurs in volatile anesthetics and pain-induced.
Pain-induced. Yeah, that's the point. Right. Okay. Good.
The typical tonic seizures occurs like taxing and waning pattern.
Very good. Very good. That's a good presentation, and it's not normally given in any of the textbooks. So all of you have to go only for some journals to get these points. So that was a beautiful article that I also read, and I have prepared my PPT based on that, a few points. And Dr. Pavitra has nicely presented that very under the headings and all these things. So remember, the treatment for shivering is classified into non-pharmacological and pharmacological. Okay? Non-pharmacological is trying to improve the surface heat of the patient so that the difference between the surface heat and core temperature is reduced. Then the stimulus from the cold skin does not go to the hypothalamus to stimulate the shivering. That is the mechanism of non-pharmacological treatment to prevent and abolish shivering. Whereas the pharmacological treatment, they all reset that again. This shivering threshold is a very important terminology that you should use in your answer so that the examiners will understand that you have understood the basic pathology that is likely to cause this problem. Okay, so mention that. And the shivering threshold value is 35.5 degrees centigrade. That is also another point you have to write in your answer. Good. Congratulations, Dr. Pavitra. Okay. Kamachi, who's the next candidate?
Candidate is Dr. Rajendra Prasad from Northern Delhi Central Hospital, sir, New Delhi. He will be presenting on enumeration of the safety features in modern anesthesia workstations.
Okay, this is usually a question commonly asked in your Viva exams, and it is a very elaborate question that you may find short of time in the exam if it is asked like this. So you have to go. Yeah, go ahead, Dr. Prasad, Rajendra Prasad. Okay. What are the safety features in the modern anesthesia workstations? That is the question. Eh? So how to present the answer?
Unmute yourself, Dr. Rajendra. Please unmute yourself.
Your mic is not on.
Good evening, sir.
Good evening. We can hear you now. Yeah.
Yes, sir. Yes, sir. An anesthesia workstation is a medical device used to generate and mix a fresh gas flow of medical gases and inhalational anesthetic agents for purpose of inducing and maintaining anesthesia. Safety features included in anesthesia workstation are safety features to the OT personnel, which includes anti-static rubber prevents static electric transfer, and also which may lead to it prevents the fires due to static electricity.
Very good.
And safety features to the patients, sir, to prevent delivery of hypoxic mixtures. Before the flow control valves, sir, pipelines. Pipelines consist of non-interchangeable quick couplers. The diameter DISS diameter and accessible pipelines which are color coded. The cylinders, sir, which are color coded and with pin index safety system, and the master switch, which is when turned on, all the alarms are turned on. And the pressure regulators, sir, oxygen and oxygen pressure failure safety devices. At the flow control valve, sir, oxygen ratio control devices. And the link 25 is beyond the flow control valve, sir, flow meter, which is touch and color coded, calibrated, and the O2 analyzers and the vaporizers, sir. And also to prevent the delivery of excess anesthetics, the vaporizers are constructed at with backflow compensation, and the locking device which prevents the use of more than one vaporizer at a time. Backflow check valve to prevent pumping effect, and the train interlock in older machines, and to prevent the excess pressure, the reservoir bag, the APL valve, and the pressure relief valve before the common gas outlet, and the pressure relief valve after the pressure regulator. The color coding cylinders, sir. Color coding is oxygen. It has black with white shoulder, nitrous oxide which has and then the pin index safety system, sir. Oxygen has 2 and 5 pin index safety system. Nitrous oxide has 3 and 5. Pin index safety system, so it consists of holes on the cylinder valves positioned in and below the outlet port, and it prevents the connection of wrong cylinder to the. Usually the cylinders used are the E-type cylinders, which can be mounted on the anesthesia workstation. It has a yoke assembly, which consists of 2 projecting pins and a hole. This pressure regulator, which reduces the pressure and keeps it constant till the end. Oxygen fail-safe devices, sir. These prevent delivery of 100% anesthetics when there is O2 depletion,
Mm.
and the shutoff, which proportionally reduces the supply of nitrous oxide and other gases when there is low pressure of oxygen.
Mm.
And oxygen ratio monitor, sir. It contains
Is your mic working?
hypoxic guard, sir.
Mm.
Hypoxic guard, which links nitrous oxide nitrous flow control valve to the oxygen flow control valve in order to maintain a minimum oxygen concentration of at least 25%.
Mm. Anything more about the vaporizers? Any safety features you know of?
Vaporizer, sir. Single vaporizer can be used at a time.
Yeah, that you have already said.
It's
Only one at a time by the
concentration.
interlocking method. Anything else? Huh?
Concentration calibrated, sir.
Concentration calibration. Okay. Anything about how it cannot be easily open? And how it cannot, when you remove it and invert it, can overflow, tipping,
Yes,
filling,
and also
about the
yes,
filling,
sir.
coding for the color coding for each
Coded and
bottle and each filling.
agent specific fillers are available,
Mm.
and also the back bar, which is selected back bar, which yes.
Okay. Then what about the oxygen flush? What is the safety feature in oxygen flush button?
Oxygen flush.
Any idea?
It bypasses the
Usually it is kept. Yeah, that is the function. But what is the safety feature included in the oxygen flush? Button is usually inside a projection. Okay, so if by accident you cannot switch it on. Okay,
yes.
So you have to put your finger inside a depressed area and then press the button and then take it off. Okay, so that it's not projecting easily outside. And in the flow meter, the downstream position of oxygen flow meter to prevent hypoxic mixture.
Yes, sir.
Then link 25 minimum oxygen flow in all the modern machines. Okay, and then battery backup for failure of power supply, because modern workstations require both electricity and pneumatic connections. Okay, so there is a battery backup and easy method of changing the carbon dioxide absorbers, which are very cumbersome in the earlier machines. Okay, so that any leak does not happen when you fit it back. Okay, and the common gas outlets. Nowadays, some machines have extra common gas outlets also. So all these things you have to mention so that you know. So instead of, you can classify them into first various levels at which the safety features are, and then divide them into high pressure zone, intermediate pressure zone, and low pressure areas. Then classify, then it will be easy to remember and also narrate your answer. Okay?
Yes, sir. Yes, sir.
You are a primary candidate?
Yes, sir.
Okay, right. You need to be congratulated for your effort to take up this and present it. Okay. So Kamashi, can I just go for my presentation?
Yes, sir. Thank you, sir. Thank you all the participants. 8 nice questions and very good effort in a short notice, sir. Thank you, sir. We can go ahead with the presentation, sir. Can you kindly share your presentation, sir?
Yeah, that's what I am trying.
In the meantime, I'll make a small announcement also. Regarding the equipments and machine safety, there is a wonderful small notes book which I have shared with Dr. Rakesh. Dr. Rajendra Prasad, you can collect it from him. It gives a beautiful description about the safety features of anesthesia machine, including the history part of it, how it evolved over a period of time since 1940s and 50s.
So is
Yes, sir.
my
Thank you.
screen visible?
Yes, sir.
Yes, sir.
Yeah, I will make it full screen. So these are the theory questions on this 3rd September 21. The first question is, describe the guidelines for regional anesthesia in patient on anticoagulation therapy. That was done by Dr. Mubin. And so what I thought was, if you present it this way, it will be better. Indications for anticoagulant therapy commonly prescribed in venous thromboembolism, pulmonary embolism, CHADS S2. All of you, I hope you know cardiovascular disease, hypertension, and diabetes, stroke. All these things are included in that acronym CHADS 2. Prosthetic valve, coronary stent, coronary artery disease, chronic atrial fibrillation. These are all the commonly pathological conditions where you prescribe anticoagulation to be taken on a regular basis. Then the drugs used for anticoagulation, you can divide them into antiplatelet agents like aspirin, ticagrelor, clopidogrel, prasugrelor, ticagrelor, cangrelor, then warfarin, which are all oral and newer oral anticoagulants, which Mubin classified into oral and parenteral. So the last low molecular weight parin and fraction or non will come under parenteral. And the guidelines, you can say which drug, whether you can continue or whether you have to stop. If you have to stop, how long before, restart, how long time after. That is the most important thing. That the timing is the very important. That is the guideline. What they are saying. They say aspirin, you can continue. And then the other newer oral anticoagulants, they say you have to stop at least 10 days before. And low molecular weight, 12 hours before and 6 hours later you can resume. So these are the guidelines that are being done. So in a short form, this is a answer for that. Second, what are the causes of intraoperative bronchospasm and its management? There's an obstruction to airflow, usually during expiration at the level of the smaller bronchiole and bronchi. Common causes are bronchial asthma, COPD, allergies like latex, viral, and inhalation irritable fumes. Drugs like NSAID, antibiotics, even neuromuscular blocking drugs also can cause anaphylaxis and produce a bronchospasm, blood and blood products. Now, bronchospasm can occur any stage of anesthesia. During induction, it can be due to intubation or volatile agents like iso and desflurane. And during maintenance, it can be due to the drugs or blood. On recovery, it can be due to secretions or aspiration or pain and lighter plane of anesthesia. Now, the differential diagnosis, you can make it into mechanical causes like kinked or partially blocked tubes, which can mimic a bronchospasm, endobronchial intubation of ET tube, stuck valves in the breathing circuits. All these are mechanical causes which may be mimicking a bronchospasm. So you have to first rule out a mechanical cause, then go to the patient and identify whether it is a hyperreactive airway like asthma, COPD, allergic or recent LRI, or inadequate depth of anesthesia, which during a painful procedure like anal or cervical dilatation. Then pharmacological agents like induction agent, neuromuscular blocking agents, analgesic, especially NSAIDs, antibiotics, blood products. Then aspiration during especially LMA or usage of an uncuffed tube and pneumothorax. These are all, and pulmonary edema also sometimes can result in bronchospasm because of the compression. Okay, so these are all the answers that you can give for that. Then management of a patient with suspected bronchospasm. First thing is you have to call for help. There is an algorithm given in the what is that UK FRCA guidelines. So on suspicion of bronchospasm, switch to 100% oxygen, ventilate by hand, stop the surgery and the stimulating or irritating agent, consider allergy or anaphylaxis, stop administration of any suspected drugs, colloid or blood products. And immediate management is to prevent hypoxia and prevent bronchoconstriction. Then deepen the plane of anesthesia, as I told earlier, with either propofol and ketamine. Ventilate through the ET tube if it is difficult. Check the tube position and check for any misplaced or blocked tube. Then, if necessary, eliminate the breathing circuit occlusion by self-inflating bag. In non-intubated patient, exclude laryngospasm and consider aspiration. Secondary management, provide ongoing therapy, address underlying cause, optimize mechanical ventilation. Again, reconsider any allergy or anaphylaxis, expose and examine the patient for any rashes or swelling and other things which will indicate that there is an allergy or anaphylaxis. If no improvement, consider pulmonary edema, pneumothorax or embolus, foreign body. So if these mechanical obstructions or narrowing of the air passages are all ruled out, then these four possibilities have to be thought of: pulmonary edema, pneumothorax, pulmonary embolism and foreign body. Then consider abandoning and aborting the surgery. Request and review for chest x-ray. Consider transfer to a critical care area for ongoing investigations and therapy. And the drugs that you can use are, as been said, salbutamol is the first choice. Then you can give ipratorium bromide also, magnesium sulfate, hydrocortisone, ketamine, ephedrine, chlorpheniramine maleate. So I used to remember this with a mnemonic: same chick, SAMECHIK, chick. Same salbutamol, A aminophylline, M magnesium sulfate, E epinephrine, C chlorpheniramine maleate, H hydrocortisone, I ipratorium bromide and K ketamine. Okay, so the same chick, totally 8 drugs. You can remember by that, and these are all the drugs that can be used. And difficulty with ventilation and falling SpO2, consider transfer to high dependency unit or ICU. Okay, these are the answers that you can give. And in the anesthesia for MRI suit, first you can give a brief description about the MRI machine and components and its working principle. There is a primary magnet, then there are 3 gradient magnets and a coil and a computer system. These are all the components of a MRI machine. So if you see this picture, you can understand. So this primary magnet creates a magnetic field and the coil sends a radio frequency, and then the hydrogen ions in the body cells are all aligned, and then you get the image transmitted to the computer where you get the picture like this. This will be the appearance. So that is how the whole thing is working. And the strength of the magnetic field, these are all points which I have mentioned for your practical Viva exam, where they may ask you what is the strength of the magnetic field, 1.5 to 3 Tesla. So if you see the MRI lab advertisements, they will say we have 1.5 Tesla, we have 3 Tesla machine. 3 Tesla is very, very powerful, not commonly used. 1.5 is very common. And 1 Tesla is equal to supposed to be 10,000 Gauss. And the Earth's magnetic field is only 0.5 to 1 Gauss is the strength of our Earth's magnetic field. And the magnetic field of 50 Gauss is marked around the MRI scanner with a line. This is called the 50 Gauss line. You can see in this picture. So this orange line which is surrounding there is the 50 Gauss line. So any equipment of ours going very close to this within this line, that will be having a ferromagnetic attraction. If it is a credit card or your ID badges or any metal containing things, will all be sucked out and flying and cause trauma. Whereas this 5 Gauss line is safer. So your anesthesia machine can be placed here. It should not go inside here. And your anesthesia machine should usually be MRI compatible and not safe. Because as I told earlier, if a machine is safe, it will not be attracted, but it will be not functioning properly. Okay? So the anesthetic challenges for MRI, if it is a short note question, you have to crush it into a small port and write. So NORA problem, remember about the soap mean. Then patient related, it usually is children and uncooperative adult or obese patients for whom you may have to give anesthesia. And then you have to use, you do a pre-operative evaluation and keep the patient nil oral. All these points which I told I have not mentioned here, but you remember that. And then use MRI specific monitoring infusion pumps, ferromagnetic objects to be discarded before going, and patients with pacemaker cannot have an MRI, and you need special circuits and compatible anesthesia machine. And the circuit commonly used is the Bain circuit, which has a length of 5.4 meters, which is 3 times the normal of the normal Bain circuit that you use. Okay, and difference between MRI safe and MRI compatible, what I told you, I have also given here. Then coming to causes and treatment of perioperative hypoxia. So I changed the wording from post-op hypoxia to periop so that we can include all the conditions. Hypoxia is a reduction in oxygen in the tissues. The types are hypoxic, anemic, stagnant, and histotoxic or cellular. The pre-op causes are pre-existing cardiopulmonary disease, most important factor in promoting post-operative respiratory complications. Already low PaO2 or a decreased respiratory and circulatory compensation. Patients in trauma may involve ventilatory and circulatory system, may cause atelectasis, shunting, as the person who said, I think Dikshit said that, and restrictive influences and pain medication. Then old age, PaO2, you have to know that it will be always little low. It is actually 100 minus age by 2. After the age of 60 years, it may be 60 to 70 only. Reduced compensatory increase in the cardiac output, and ventilatory response to hypoxia is reduced. So they are likely to become hypoxic, and obesity is an important cause for postoperative hypoxemia, especially if they have OSA. So you have to immediately start the patient on their CPAP or BiPAP, which they have been using. And severe anemia may be present rarely and except in the worst emergencies. Restriction of respiratory motion in the form of tight binders or abdominal distension can cause significant reduction in PaO2 and cause decrease in available ventilatory compensation. Now, intraoperative causes classified into 2, the problems with oxygen delivery or problems with the patient. So oxygen delivery can be caused by decrease in oxygen in the inspired air, hypoxic mixture, or decreased alveolar oxygenation, decreased oxygen tension in the alveolar blood, arterial blood, decreased oxygen content in the arterial blood because of anemia, decreased cardiac output, increased tissue metabolism. All these things can result in hypoxemia. And problems with the oxygen delivery can occur at these levels. At the central oxygen supply, pipeline distribution, oxygen delivery at the anesthesia machine, or within the anesthesia machine, or at the ventilator level, or the circuit, or endotracheal tube. All these levels you can develop a then problems with the machine can be hypoventilation, reduced FRC, increased airway resistance, atelectasis, absorption atelectasis, diffusion defect, shunt, inhibition of hypoxic pulmonary vasoconstriction, which will result in excessive shunting. So this is another important factor. And poor oxygen delivery to tissues and increased oxygen demand. All these things can result in hypoxia. Then who are the patients at risk of hypoxia? Preoperative smokers with COPD, patients with reduced FRC like elderly, obesity, diabetes, general, and surgical pathology like restricted ventilation and the inflammatory response, sedation, hypothermia, and fluid overload. All these things are patients who are at risk. Then the mechanism of hypoxia can be due to lack of alveolar ventilation, lack of alveolar perfusion, or decreased alveolar diffusion. So all the 3 components which are very important for transfer of oxygen and carbon dioxide: lack of ventilation, lack of perfusion, and diffusion capacity. So if there is a lack of alveolar ventilation, can be due to upper airway obstruction, respiratory depression, pneumothorax, atelectasis, or bronchospasm. Lack of perfusion usually due to pulmonary embolism where there is no blood flow. Decreased diffusion can be due to pneumonia, ARDS, or pulmonary edema, or aspiration. All these things can, pneumonia may be due to aspiration also. So this flow chart is very useful for you to quickly write the answer in the exam within the time available. Okay. Then coming to placenta PERCRETA management, normally the placenta adheres to the decidua basalis layer, allowing for a smooth separation of the placenta from the uterine wall after delivery. In patients with abnormal placentation, the placenta has invaded past the decidua basalis, and this picture will tell you this is the normal placenta, and this small area is the decidua basalis, stratum basalis of the endometrium. So the placenta is outside this endometrial lining, whereas in the accreta, it is invaded the decidua basalis. In INCRETA, it has gone into the myometrium. In PERCRETA, it has gone out of the myometrium and gone to the neighboring organs. So placenta accreta, abnormally adherent placenta, is one of the two leading causes of peripartum hemorrhage and the most common indication for peripartum hysterectomy. This has an anesthetic implication because it is necessary to prepare for the potential danger of major hemorrhage. That is the most important challenge in that. So normally elective cesarean section with consented hysterectomy under general anesthesia is the planned procedure. In view of the expected massive blood loss, adequate packed red blood cells and blood products should be available in the operation theatre. This patient should be placed on the operating theatre with a wedge under the right hip. That is expected as a part of your answer in any obstetric case coming for anesthetic question. So both in practicals and in theory, you have to mention that I will keep the hip wedge under the hip, even though you normally practically don't do that many times. Prior to cesarean section, urologists do a cystoscopy to rule out intravesical invasion in placenta PERCRETA and insert bilateral ureteric stents to avoid ureteric injury and identification during hysterectomy, and a Foley's catheter also is inserted to collapse the bladder. Two IV lines, 16 and 18 gauge, are secured. A 20 gauge arterial, so invasive monitoring with the direct arterial line is a very important thing, which will help in beat-to-beat measurement, and hemodynamic stability can be more accurately assessed. And also it will help in doing a periodic ABG to find out whether the patient is going in for any acidosis or other problem, hypoxemia is persisting. And under ultrasound guidance, you can put in a 7-point French triple lumen central catheter, which will help in rapid transfusion. The standard monitors are attached, and then you can give either propofol or thiopentone for induction. Tracheal intubation can be by suxamethonium with a cricard pressure, and then anesthesia maintained with oxygen and air and sevoflurane. This is a tracherium. This is a better method. And after delivery of the baby, you can give carbetocin or oxytocin to contract the uterus. Placenta left in the uterus. The placenta is not removed. Hysterotomy wound is sutured to avoid partial placental delivery inducing hemorrhage. So both the uterine arteries are clamped and hysterectomy done. That is the normal procedure. Now it is a multidisciplinary approach. Actually, this particular sentence should come in the very beginning of your answer, so that the examiner will get the impression that you have understood the problem. So the team should include experienced obstetrician, surgeon specialized in pelvic surgery, anesthesiologist, and urologist, neonatologist, blood bank team capable of administering multiple blood products, and an intensive care facility where the patient can be monitored after surgery. These are all the people involved in the team. And optimum management of placenta PERCRETA requires early detection and a planned cesarean hysterectomy, ideally at 34 to 36 weeks. So you don't wait till the final stage when suddenly the labor may start, and then it becomes more messy to manage these patients. Regional or general anesthesia can be used, even though normally general anesthesia is the recommended technique. They have done regional also, but the indications for regional anesthesia is when you know that it is a very small attachment and there will not be any severe massive hemorrhage. In that case, then you can go for regional. The advantages are it can provide a better postoperative pain control, reduce the risk of aspiration, reduce bleeding, allow for better mother-baby bonding, and decrease fetal exposure to drugs. And another thing is you are avoiding the difficulty in managing a difficult airway or failed intubation. That is the other advantage. That is why regional has become the mainstay of your cesarean section anesthesia. Disadvantages include the risk of hemodynamic instability. In addition, simultaneous management of potential airway during surgery is clearly not a choice. Supposing you have to convert it to GA, at the time it will be difficult. So that is why usually people prefer general anesthesia, which allows a better control of ventilation as well as better hemodynamic stability in the event of massive hemorrhage. And the duration of hysterectomy may sometimes take longer compared to very simple cesarean. At the time, the patient becomes restless and the pulling and traction of viscera causes pain and nausea, vomiting, all these things will happen. So to avoid all these things, prefer to go for general anesthesia straight away. And a hyperemic pelvic viscera require careful dissection. So your patient should be quite immobile and good relaxation should be there. So placenta percreta may be perfused by extra uterine vessels also. It is not only the uterine artery which may be giving the blood, but there may be extra uterine vessels, and this bleeding cannot be controlled by uterine artery ligation alone. So for that, now endovascular interventions are being done. Interventional radiologists have developed and refined percutaneous techniques to occlude the specific uterine arteries. One preoperative strategy is to endovascularly embolize the internal iliac arteries or occlude those arteries with temporary balloons. Alternatively, the collateral pelvic vessels can be embolized percutaneously with ligation and internal iliac arteries performed by surgical team. That is, when you plan for hysterectomy, you can straight away ligate. But if you plan to retain the uterus, then you have to go for balloon occlusion. It is called intra-abdominal aortic balloon occlusion. Okay, anticipated arterial bleeding from the placenta can also be managed intravascularly. And prophylactic pelvic artery catheterization is to allow the avoidance of hysterectomy and preserving the uterus. And as in some centers, high-risk cesarean deliveries are performed in interventional radiology suites itself to facilitate for this arterial catheterization and embolization. Caution required if cell salvage is used because it can cause amniotic fluid embolism and the risk of severe hypotension can be happening. And then damage controlled resuscitation. This is one of the short note that was asked in the last exam in your theory paper for DNB. And this was introduced by the US Army Institute Surgical Research, which said transfusion of one packed RBCs, one FFP and one platelet without much of crystalloids or colloids produced a better result than your multiple whole blood transfusions. Now coming to blood conservation strategies and definition of massive blood transfusion protocol. What is blood conservation? It's defined by the Society for the Advanced Blood Management as an approach to surgical patient care that utilizes the latest drugs, technology, and techniques to enhance a patient's own blood supply and decrease blood loss. So that is the definition of blood conservation: decrease blood loss and enhance patient's own blood supply. The aim is to reduce or avoid unnecessary transfusions. That is the idea of blood conservation. And the task force says transfusions are rarely indicated if the hemoglobin is more than 10 grams, always indicated in patients below 6 grams, and between 6 and 10 you have to take into consideration the ongoing indication of organ ischemia, the rate and magnitude of any potential for actual bleeding, and patient's intravascular volume status, risk of complications due to inadequate oxygenation. These are the points you have to take into consideration. If it is 7 or 8 like that, then use blood components separately, promote blood conservation as much as possible. Now, what are the methods by which can be accomplished the conservation is preoperative evaluation and risk stratification, reduce the need for blood transfusion. The last step is the autologous transfusion. So in the pre-op evaluation, optimization of hemoglobin by giving the patient a good assessment, screening, and correct the nutritional anemia with iron therapy, dietary advice, and B12, and careful attention to patient medical history, pre-op methods. If the patient on antiplatelet and NSAIDs or some herbal drugs also can produce this problem, so identify them also. And pre-operative autologous donation. If the patient's hemoglobin is more than 12 or 13, you can bleed from the patient itself and you can give him erythropoietin therapy. And if it is an elective surgery, you can delay that so that you can optimize the patient well. Now coming to the method to reduce the use in surgery, surgery should be elective, correct the hemoglobin level, stop the drugs that interfere with hemostasis like your antiplatelets. Intraoperatively, posture, use of vasoconstrictors, use of tourniquets, use of antifibrinolytic agents, use of tranexamic upretronine and controlled hypotension or regional anesthesia. All these things are methods to conserve or avoid blood loss so that you indirectly conserve blood. Postoperatively, blood can be salvaged from drains into collection devices that permit reinfusion if it is not malignancy or any infected patient. And volume expanders, you can use acute volume replacement, hydroxyethyl starch, dextran, and hemaxil, and blood substitutes. That is where your perfluorocarbons come into play. So the blood substitutes, HB solutions, which increase the hematocrit, and but systemic and pulmonary hypertension is the problem. Then perfluoro emulsions, oxygen solubility 20 times of plasma, decreases platelets and require high PaO2. Focus is on the ability to carry oxygen, not on further functions of the blood. Effective only for 12 to 24 hours. So it's for short-term use, it's an ideal method. And cell salvage is the last one where you can recycle the blood by collecting it, washing it, suspending it in normal saline and sending it. But it will dilute, it will cause a dilutional coagulopathy. You are giving back only the RBCs, so other coagulation factors are not there. So there is a danger of coagulation failure. So in autologous blood transfusion, collection, reinfusion of the patient's own blood and blood components. That is what is the meaning of autologous blood transfusion. Why you should do that is because it is a fully compatible blood. No risk of transfusion of transmitted diseases like hepatitis, CMV virus, and HIV. Avoidance of alloimmunization, improved oxygen perfusion by low viscosity, and they can do either as an acute normovolemic hemodynation, where you can get a fresh whole blood on the same day of surgery, less dependent on blood bank stock. Okay, so if the patient himself can donate, nothing like that. And isovolemic hemodilution, 1 to 2 units of patient's own blood is withdrawn at the beginning of the surgery on the day of surgery. Blood volume restored with crystalloid and colloid. Patient bleeds thin blood during procedure. So because of this dilution, the blood that is lost during surgery becomes thinner or hematocrit is less, gets own blood back at the, so use this blood which you have collected after the surgery is over so that you don't lose that also intraoperatively. So may stabilize the patient intraoperatively with the other fluids, and then after the surgery is over, give the fresh blood back to him. And the criteria for doing that, the age of the patient should be less than 65. He should have at least a minimum of 11 grams of hemoglobin, and he must be weighing at least 50 kg weight. And there should be no severe heart or lung disease or abnormal bleeding tendency, no bacteremia at the time of donation, no history of previous hepatitis or HIV. Cancer is not a contraindication for that. So if a patient is having a good hemoglobin and is undergoing a cancer surgery, you can do the same thing in him also. It is not a contraindication. Pre-surgical autologous blood donation is the one which you do well in advance. Best choice for patients with rare blood groups or irregular antibodies. 1 unit per week is the time interval, and patient should take iron and erythropoietin. Then he donates 1 unit per week. Normally 3 to 4 units are collected. So over a period of 1 month, you can collect every week 1 unit and store 3 to 4 units. Last donation must be at least 3 days before the surgery. So you should not do it within 72 hours of surgery. Blood is stored and kept for patients for reinfusion during after operation. Then controlled hypotensive anesthesia or induced hypotension. This is also one of the short note question. It's a current perspective. Cell salvaging procedures and use of regional anesthesia and tranexamic acids. These are all points that you have to again to remember easily. I have mentioned that. Then definition of massive transfusion. He defined nicely. So these are all the various definition. And in pediatric patient, transfusion of more than 100% in 24 hours, transfusion support, replacing ongoing hemorrhage of more than 10%, and replacement of more than 50% within 3 hours. Okay, so they are more or less the same definition, but a little modification here in pediatric massive transfusions. And what are all the, how can you predict whether a patient will require a massive transfusion or not? That is the trauma associated severe hemorrhage score incorporated 7 clinical and laboratory variables into a composite score to predict the need for massive transfusion. Hemoglobin, base excess, systolic arterial pressure, heart rate, presence of free intra-abdominal fluid, or complex fractures, and gender. Okay, these are all taken into account, and you know that beforehand that this patient may require a massive transfusion. The other group of workers, they found out that simple parameters also appears to be as good as other more complex. Presence of penetrating trauma, systolic pressure less than 90, heart rate more than 120, a positive focused abdominal ultrasound fast for trauma with a bleeding inside the peritoneal cavity, or if any of the two of the above 4 parameters are positive, then there's a likelihood of massive trauma. So the simple 4 penetrating trauma, systolic BP less than 90, heart rate more than 120 with a blood inside the abdomen. If any 2 of these 4 things are there, you have to be prepared for massive transfusion. Now another question that was asked in the last exam, that is why I included this, which is called early trauma-induced coagulopathy or acute coagulopathy of trauma. Historically, early trauma-induced coagulopathy or acute coagulopathy was attributed to colloid, crystalloid or RBC transfusion. So in a patient who comes with a severe trauma, to resuscitate him, if you keep on giving lot of crystalloids with RBC, pectoral RBCs, then other coagulation factors are not there, so patient goes into coagulopathy. That was the earlier thinking. However, subsequent studies in both adult and pediatric trauma patients demonstrated that this problem of ETIC was present in 24% and up to 56% of the severely injured patient, usually within 30 minutes of injury, even before receiving RBC and fluid. So earlier concept or reasoning given was you dilute the blood with crystalloid and only packed cell red blood cells. Whereas later they found within 30 minutes of injury, they developed this even without transfusion. And what are the reasons for that? That is demonstrated here. So severe trauma occurs, bleeding occurs, and the bleeding leads to either you give colloid and crystalloid, which is causing a dilution, or massive RBC transfusion is given. But before that, tissue hypoxia, acidosis, and hypothermia, hypocalcemia, all these things are contributing to coagulopathy. So even if you don't give RBCs and colloids, because of the tissue hypoxia, acidosis, hypothermia, hypocalcemia, they have been now found out to be the cause of early trauma-induced coagulopathy. Now there is another thing called breaking the bloody vicious cycle. How to prevent, that is, patient is actively hemorrhaging. You give blood, again he bleeds more and becomes a vicious cycle. So how to break that is control hemorrhage, use best possible resuscitation products, prevent hypothermia is very important, prevent hemodilution, and treat coagulopathy. These are all the steps in preventing the bloody vicious cycle, which means bleeding patient given blood again bleeds more. That is what is called the bloody vicious cycle. Okay, so active hemorrhage, iatrogenic factors, core hypothermia, progressive coagulopathy, cellular shock, again core hypothermia, acidosis, then tissue injury, contact activation, massive transfusion, contact activation, pre-existing diseases, clotting factor decline, all this leading to coagulopathy. So patient bleeds more and more. So you pump in blood on one side, he bleeds on other side, and it becomes a vicious cycle. That is what is called the bloody vicious cycle. So the current component therapies in the USA, they are administering RBC, plasma and platelets to break this particular problem. So 630 to 650 ml product with a hematocrit of 29%, whereas coagulation factor activity is 65%. If you store them with storage defects taken into account, this mixture should produce at least a hematocrit of 26%. And the availability of factors should be 40 to 50%. And in both cases, platelet will be 90,000 per cubic millimeter. Okay, platelet is also an important component to arrest the bleeding. So these are the components which are given. Now coming to what is the protocol, MTP is a way to coordinate the care of the patient. So the protocols have been always introduced into therapies to coordinate the care. That is for any protocol, that is the basis. So you require that for massive transfusion to facilitate communication between different services, the trauma team, the nursing team, the transfusion medicine and other lab people. Avoid delay in clinical care, testing and finding out your therapy results, blood product transfusion and nursing care. So MTP is a way to assure good patient care by having a standard protocol on specific actions to take for each and service involved. And also they demonstrated improved patient survival with a proper protocol. So if you go by a sequence of steps, then it provides a better care for the patient and the outcome is better. So the components are when and who should initiate this protocol. The first one, who should be in charge. Notification of the transfusion service and the starting and stopping of MTP should be under control of one person. Laboratory testing algorithms like prothrombin or partial thromboplastin, all these things should be frequently done. Nowadays, with the advent of tech and ROTAM, this sending blood every time to the lab and getting it has now been removed. So tech has improved the quality of treatment much more. So this has overtaken over the previous all other tests that we were doing. Blood product preparation and delivery should be already predetermined and packages should be kept ready so that immediately it will be available. Other patient care needs like blood warmers and nursing care also should be kept ready. And it can include preparation and administration of not only blood and blood products based on laboratory results or your TEG and NOTAM, and the number and timing of blood component delivery, laboratory testing algorithms and other aspects of protocol may vary between institutions, but most current MPTs use the predetermined transfusion packages. So you will have RBCs packed red blood, RBCs ready, platelets kept ready at room temperature or body temperature, FFP thawed and kept ready, cryoprecipitate, like that. Everything has been kept ready in anticipation and then made to be available immediately so that the further bleeding can be stopped. And lastly, lab monitoring. Already we have seen that this is the metabolic panel is also there to find out other things like lactate, potassium, calcium. So not only the quality of the clotting, but also other metabolic assessments. And point of care ABG measurement is also now available for monitoring oxygenation, which are all included in the MTP. And the initial intervention, what you should do is you should have two large IV bore cannulas or a central venous catheter, crystalloid 3:1 or colloid 1:1 ratio for expected blood loss. Then limit crystalloid as much as possible. Then lab should do all the investigations like types grouping, cross matching, total blood count, initial assessment of all the coagulation profile, electrolyte, urea, creatinine, calcium, everything should be done. Then continuous monitoring of volume status, acid-base status, and rewarming, aggressive warming of the patient. Prevent or reverse acidosis as quickly as possible. Correction of hypocalcemia is a very, very important step because you are giving so much of citrated blood. So calcium gluconate should be given 1 gram IV slowly to get the targeted ionized calcium 1.2 to 1.3. So this can be done by, previously we were giving empirically after every 3 to 4 units of blood transfusion, we used to give 10 ml of calcium gluconate. But nowadays they advocate that you measure the ionized calcium and then if the value is 1.2 or 1.3, you need not give. Otherwise, you have to give supplement and then correct it. Transfuse with unmatched group or negative negative group in case of emergency, and then repeat lab for coagulations. Now, complications can be classified into transfusions reactions like allergic, hemolytic, and febrile, and then the immunological reactions are TRALI, transfusion-induced immunomodulation, graft versus host diseases, post-transfusion purpura. All these are all immunomodification. And metabolic or hypocalcemia, hypomagnesemia, all these electrolytes will be diluted, and hyperkalemia or hypokalemia can also happen depending upon if the re-entry into transfused RBCs happens, you get hypokalemia. Or if there is a hemolysis of the RBCs because of storage or irradiation, they will get hyperkalemia. So both are possible. And metabolic alkalosis can happen if citrate overload occurs. And so monitoring acid-base status is very important. If there is hypoperfusion and hypoxemia, acidosis will happen. Hypothermia is another one. Other infections can happen. And along with that, volume overload or under overload, as the doctor said, is also possible. Okay. So that is about massive transfusion. Then coming to postoperative, pathophysiology management of postoperative shivering is a syndrome involving involuntary oscillatory contractions of skeletal muscles. And it's common after the effect of anesthesia or targeted temperature modulation. In normal physiology, shivering is a physiological response to improve the core temperature, to increase the body heat by peripheral vasoconstriction. Whereas postoperative shivering is an oscillatory muscular activity during early recovery of anesthesia. It is defined as a fasciculation of the face or head or muscles of hyperactivity lasting longer than 15 seconds, which doctor said. The fundamental tremor frequency of an electromyogram in humans is typically 200 Hz. The basal frequency is modulated by a slow 4 to 8 cycles per minute in a waxing and waning pattern. This is a normal response, how our muscles act. There are two different patterns of shivering. One is the tonic pattern, another is the clonic pattern. And in tonic pattern showed consistent sinusoid top of normal shivering. It is a thermoregulatory answer to intraoperative hypothermia. So tonic pattern is a response to hypothermia, whereas clonic pattern is a component of normal component of thermoregulated shivering, and it seems to be specific from recovery during volatile anesthetic agents. It is not a normal component like a tonic. This pattern of shivering might come from the loss of inhibition produced by the general anesthesia in the control of spinal reflexes. Now, shivering is elicited in the preoptic region of the hypothalamus when it is cooled. That is the brain in the hypothalamus, the preoptic region. If it is becoming cooler because of the decrease in core temperature, then what it does is it sends efferent signals mediating shivering descent in the median forebrain bundle. Okay. Then spinal alpha motor neurons are triggered, their axons and final common pathway for both coordinated movement and shivering. This alpha motor neurons are responsible for our coordinated movement as well as shivering. So they are stimulated. A typical cold tremor has a specific rhythm in the form of group discharge in the electromyography. So during continued cold stimulation of the skin or the spinal cord, motor neurons are recruited in a sequence of increasing in size, starting with small gamma motor neurons that are followed by small tonic alpha motor neurons, and finally large phasic alpha motor neurons. So step by step, all the motor neurons are stimulated, so the body goes into sort of oscillatory contractions. In surgical patients, research has demonstrated a difference in incidence of non-thermoregulatory shivering in normothermic postoperative patients. A tonic stiffening occurs early, observed as a non-temperature dependent effect after isoflurane anesthesia. Another observed pattern is spontaneous electromyographic clonus that requires both hypothermia and residual isoflurane end-tidal concentrations. So the anesthetic agents produce a normothermic shivering, whereas hypothermia induces hypothermic shivering. The shivering score, as she mentioned by Matthew, there are 4 grades, 0, 1, 2, and 3. See, 0 means no shivering, 1 is mild facial fasciculations, and then 2 is visible trembling, and 3 is gross muscular activity. Okay? Then the etiology of shivering is cold-induced thermoregulatory shivering remains an obvious etiology. The phenomenon has been attributed to other causes like pain, disturbed spine reflexes, and decreased sympathetic activity and respiratory alkalosis. All these 4 are also other causes: pain, disinhibited spine reflexes, decreased sympathetic activity, respiratory alkalosis. The conventional explanation for post-anesthetic shivering or tremor is anesthesia-induced thermoregulatory inhibition abruptly withdrawn or dissipates, okay, thus increasing the shivering threshold towards normal. So the discrepancy between the persistent low body temperature and the new normal threshold is the important factor for the shivering to start. Then perioperative hypothermia is defined as a core temperature of 33 to 35 degrees centigrade, as I told you earlier, whereas the shivering threshold is 35.5. So when the body temperature, core temperature reaches 35.5, our body will start shivering. But when you are under anesthesia, you go up to this temperature. So when recovery happens, your temperature shivering threshold is already attained. So once you reach this temperature, your body will automatically start shivering unless you have maintained the core temperature above this level. Okay, that is why maintaining the intraoperative temperature is a very, very important point that all of us have to remember. So one of the important functions of the rostral ventromedial medulla is to modulate the amount of pain and temperature input ascending from spinal cord by gating the transmission of neuronal signals. That is the reason why if pain is not properly controlled, shivering also happens, because both are modulated in this part of the medulla. Okay. Now coming to shivering can be divided into normothermic and hypothermic, which correlates with the cutaneous vasoconstriction in response to hypothermia and normal vasodilatation with occurring in pain. And clinical impact of this is important function of shivering is elevating the body's core temperature. Shivering is uncomfortable. Some even find it accompanying cold severe worse than surgical pain. So it also causes increase in oxygen consumption, induces lactic acidosis, carbon dioxide production, and catecholamine secretion, resulting in increased cardiac output, heart rate, and arterial pressure. Shivering also impedes monitoring techniques. Your pulse oximeter may not work properly if there is a vasoconstriction and constant movement of the fingers. Increased intraocular and intracranial pressures will happen, and especially disturbing mothers during labor and delivery. And vigorous shivering increases metabolic heat production by 600% and increases oxygen consumption by 300 to 400%, which can result in hypoxemia. So even if you are giving supplemental oxygen, because of the enormous increase in the consumption, patient may still be hypoxemic. It can lead to critical ischemia in the postoperative period. And shivering may also be increased with adrenergic and sympathetic hyperactivity, leading to myocardial ischemia. So if the patient has got coronary artery disease, don't allow the patient to shiver at all in the postoperative period. Shivering may cause patient discomfort and increase the likelihood of postoperative complications such as infection, pain, and bleeding. Shivering may be associated with delayed wound healing and increased in the hospital stay. The increase in the metabolic requirement also predisposed to difficulties patients with existing intrapulmonary shunts or fixed cardiac output or limited respiratory reserve. So the treatment part is there are many therapeutic strategies, but everything is empirical. So far, nothing has been proved to be the ideal one. Two main strategies are pharmacological and non-pharmacological. So non-pharmacology is forced air warming. That is the common method which we do, which is very, very good, where the active cutaneous warming is done to reduce shivering in the perioperative mechanism. The mechanism is the cutaneous warming increases body heat, limiting the heat distribution. Normally what happens when your surface skin becomes cooler, the core temperature is the one which comes to the surface to keep it warm. So the core temperature drops. By keeping the surface warm, you prevent this migration of the inner heat coming out. So the core temperature is always maintained. That is the simple mechanism by which this works. Then passive cutaneous warming is what is called the application of cotton blanket or elastic bandage or warming bed and all that. Active method is the electric heating, water circulating garments, and forced air warmer or bear hugger. All these things are active cutaneous warming. So mainly it is only keeping the surface warmer by all these heating elements is the non-pharmacological therapy. Coming to pharmacological therapy, many drugs have been shown to be used, starting from opioids, alpha-2 agonists, anticholinergics, central nervous system stimulants, corticosteroids. All these things are a few one. And many of them have found that pethidine is a very good drug, which is given, and tramadol is another one, ketamine, ondansetron, all these things have been used and they are all highly effective. So the first recommended drug is tramadol, second is pethidine and fentanyl, third is physostigmine, fourth is ketamine, magnesium sulfate, and fifth is clonidine, dexmedetomidine, and last ondansetron and dexamethasone. So these are all the group of drugs which are used as a pharmacological therapy, but they should be given at the beginning of surgery itself to prevent the shivering. It is most of them are useless if you give after the patient has started shivering. So it should be given as a prophylactic therapy so that you can avoid or abolish shivering. Now coming to the last question, safety features in modern anesthesia machine. You can subdivide them into what are the safety features in gas supply, safety features in flow meters, vaporizers, fresh gas delivery, that is breathing system, ventilators, scavenging, and monitoring. These are the 6 headings under which you can classify the safety features. Then you can again classify the gas supply into high pressure system where gas cylinders are to prevent wrong gas being used. The gas cylinders are color coded, international safety standards, and there is a pin index system. This is the basic 2 things that you have to remember about the gas cylinders. Pin index system prevents the incorrect gas cylinder from being attached to the hanger yoke of a wrong segment. Then the pressure relief valves are fitted in all cylinders to vent the cylinder content. That all of you would have known in the valve block there will be a pressure relief device, and pressure regulators which you see in the machine on the, especially for the oxygen, is one which tells you about the constant pressure in the, what is the pressure inside the anesthesia cylinder, and if there is any excessive pressure it will blow out and release that pressure. Okay, that is also one of the things that is there. Then comes the intermediate pressure system, which consists of Schrader probe, which you insert into the pipeline outlet in the wall. Then hoses are color coded, kink proof and flexible. Gas pipelines at the machine end are in unidirectional valve and machine end is color coded also. And specificity of gas service is there. Then pipeline pressure indicators are there in now the modern machines. Previously, we used to have only an indicator for the oxygen cylinders which are attached. Now, all the modern machines have both the cylinder pressure indicator as well as the pipeline pressure indicators are there. Then oxygen failure alarm, a loud audible alarm which should be minimum of 60 decibels and it should not be muted. That's a very important thing. Normally any alarm if you can silence for a few seconds, but this is not possible in this so that it will sound for at least 7 seconds to capture your attention. Okay, so when there is an oxygen fail there, it is predetermined to do at a safe threshold. Older machines had what is called the Ritchie whistle. So one of the short note, questions they may ask you in the Viva, what is the name of the whistle or the alarm? It's called the Ritchie whistle to alert the oxygen pressure when it is decreased to less than 260 kilopascals. It is linked to the gas shutoff valve. And oxygen flush is a switch located in a shallow recess. So normally if you see that it will not be on the surface, it will be inside a small depression so that it can be activated. It will not be accidentally turned on. That is another safety mechanism. Then coming to low pressure system, the flow meters are consistent of low pressure. So for easy identification, the knobs are fluted and larger, color coded. The names are written on that. All these things are normally you prepare for your Viva, you know all these things. And the oxygen flow meter is located in the downstream to avoid a hypoxic mixture. And nitrous oxide flow meter is set up that is automatically disabled when oxygen flow meter is set to deliver less than 21%. So this is also called the hypoxic guard where without opening the oxygen, you cannot deliver nitrous oxide. That is called the hypoxic guard in the flow meter. Then for hypoxia prevention, there is a mandatory minimum oxygen flow in the newer machines. So the question is the newer workstation. So they have a mandatory minimum oxygen flow which is not available in the older machines. And the flow is variable between 50 to 250. And as soon as you switch on the machine, automatically it will be start delivering. So a few machines in this base flow will be there. Once the power switch is on, it will all start working. And then minimum oxygen ratio is another one which is available for at least delivering more than 21%. And mechanical linkage is there to connect nitrous oxide and oxygen so that minimum 25% oxygen is assured all the time. And with the modern electronic gadgets and flow meters, you have an electronic proportioning device which is available, which also decides a preset minimum concentration of oxygen. And there are alarms to tell you when there is a low flow of oxygen or if the desired concentration is not delivered. Then vaporizers have a stiff button that has to be pushed to turn that. That is one of the important things. Earlier it was only a lever type. Now all the vaporizers have this sort of stiff push button to prevent all the vaporizers from working simultaneously. There is an interlocking system which he mentioned, and only one vaporizer works at a time. There are pressure relief devices located between the common gas outlet and vaporizer, and it protects the anesthesia machine from venting gas to the atmosphere if high pressure develops after the delivery from the vaporizer. And another few things in the new modern vaporizers they have separate transport setting. That is what is called the non-tipping setting, which will prevent spillage. So it will be having a mark as T, where so if you turn the dial to that position T, you can even make it upside down, nothing will spill out. And all the new vaporizers have keyed filling or funnel filling system with unique sizing of the filling and funnels, and also have specific bottle collars, which are spilling adapters and connectors, and they have color coding also. And then comes the common gas outlets. In the newer machines, they have more than one common gas outlet. Therefore, machine standards ensure that such machines only once should function at any given time. So that is, if you are going for a newer machine, you have to check with that. And scavenging systems all have 30 mm diameter connections. Normally in the machines, we have only 15 and 22 mm. So to avoid a misconnection, all the scavenging system connectors are 30 mm connectors, and there are negative and positive pressure relief valves incorporated in the scavenging systems. And every anesthetic machine installed with a standard oxygen analyzer also is there nowadays. And low pressure analyzer is there, a high pressure analyzer, a spirometer, everything is there. And exhaled gases analyzers are also included. Then coming to mandatory monitoring systems, which should be available in all the anesthesia machines in the modern workstation, are ECG, blood pressure cuff, pulse oximeter, CO2 and tidal CO2 monitor, tidal volume and airway pressure monitor. All these things come automatically. Other monitors which can be installed depending upon the anesthesia provider are temperature monitor, peripheral nerve stimulator, end-tidal vapor monitor, ultrasound detector for pneumothorax. All these things are optional. And where high risk patients, you can have a invasive blood pressure monitor, CVP monitor, and intracranial pressure monitor, transesophageal echocardiography, sensory motor potential, EEG, fetal heart monitor, uterine contraction monitor, and cerebral monitors. All these things are very, very specialized monitorings which are available only for high risk patients. Okay. So that concludes the presentation. Shall we go back?
Yes, sir. Thank you.
Thank you. So was it like a ready reckoner? No?
All postgraduates are encouraged to give their feedback.
Yeah.
How was the session? One by one. Dr. Pratik? Dr. Pratik Shukla?
Yes, sir. Good evening, sir. Sir, hi. It was a really very knowledgeable session, sir. I just got to know what my mistakes were, what point I left. It was
Thank you.
intriguing to know, sir. Thank you, sir.
Thank you very much. Right.
And Dr. Pavitra? Dr. Pavitra?
Sir, can you hear me?
Anything you got? Yeah. We want to hear from you. How was the session and was it useful for you?
Sir, very useful, sir. It was very useful, and I have missed some points which I got to know by sir's presentation, sir, regarding the clinical impacts and all.
Okay, one small suggestion is whenever you are attending the WebEx meeting, please use the laptop or desktop. A mobile will be simultaneously operating a lot of apps, so your bandwidth will not support the presentation. So your audio and video will not be so continuous. Okay, please.
Okay.
And Dr. Preeti from Bombay. Dr. Preeti.
She has left. She got bored. Okay.
Dr. Mubin.
Sir, the presentation is as usual was very good, sir. And I also learned from other presenters also. And at the end, the SAS presentation is enlightening. I missed certain points and I could get those points, especially in those anesthesia.
So shall we continue the same way? What is your suggestion? Hello?
Definitely, sir. Definitely, sir. It will be more helpful to us, sir.
Yeah.
What point we are missing out, we'll just know.
Yes.
Dr. Prasanna. Dr. Prasanna from ICF is also there, sir. Dr. Prasanna. Dr. Prasanna, I think he's not there. Thank you very much, sir. I personally am very much obliged to your kind support for our students, sir. And it is really very, very helpful to me also in arranging such classes for our postgraduates, and personally also learning from such an experienced and versatile teacher. It's a great blessing on us, sir, upon us. And I want to add a few comments for our postgraduates, sir, with your permission, that this class cannot be exhaustively covering all aspects of the question and answers that will be asked in DNB or MD exam. So sir's advice and all these presentations cannot cover each and every aspect of our textbook and day-to-day experiential learning. So my humble suggestion is that take the lead from sir's way of presenting and understanding things, and you can try answering in your own pattern, like organizing your answers for the concerned question, be it practical, be it viva voce, be it theory questions, try to understand the wordings in the question. Like if they are asking enumerate, then just try to list out the things as many as possible, cover as many correct responses as possible, rather than putting effort in describing in detail. Similarly, when they ask elaborate on one particular thing, then better to elaborate each and every aspect of that particular scenario. So understand the question better and put your answer in such a way that it captures the relevant points for the examiner who corrects the paper.
Yes.
And be very specific to the particular part of the question. Even in Viva, if you are very clear about the answer, be very specific, and if you are not clear, you can even ask once more to the examiner what sort of area you need clarification from the examiner. And if you, even after that, you don't know the answer, without wasting time for the examiner, you can only say that I do not know, sir. Okay, then the examiner can proceed to the next question, which will give you a better opportunity to answer further. Don't get stuck anywhere, and organize your answers in such a way that all these comes with practice only. So I strongly recommend you try to answer one question every day in an organized manner, and try to discuss this with your senior colleagues and your local faculty. And let us practice these sessions every Friday with sir's permission and sir's guidance. Sir, I need your continued support, sir. On behalf of all our students, I request your continued support for these academic activities.
Sure, sure.
Thank you, sir. Thank you. And thank you all the participants. Thank you, students. And you can involve as many postgraduates, even other from non-railway organizations also, and let them all be benefited from our sir's great effort. I sent the questions only 3 days back to sir, and he has taken all the pains to prepare such wonderful slides, and it is very, very handy for our postgraduates during any exam preparation. Not only for the content, but the pattern and the structured way of answering any question will really impress any examiner who will be correcting your papers. Thanks a lot, sir. Thank you. Thank you so much, sir.
Thank you very much. Thank you. Good night. Thank you. Thank you.
Sir,
Shall we? Yeah, yes.
Thank you, sir.
hello, sir.
Yes, somebody is. Hello, hello. Who is that?
Sir, Pavitra, sir.
Tell me.
Sir, one request, sir. Sir, if the PPT being shared in the group, it will be useful for us for the revision in future.
I will send it to Dr. Kamakshi, and you can get it from his mail ID. You can get.
Thank you so much, sir.
You're welcome. Okay. Sure, I'll do that. No problem.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you.
Shall we sign off the meeting, sir?
Yeah. Sign off. Thank you.
I have the recording of this entire classroom, sir, and I have posted everything in our YouTube channel. I will share the YouTube channel for all our postgraduates.
Okay. Thank you very much.
Thank you, sir. Thank you.
Thank you.